Any questions about anything? No? Okay. So, oh, you don't need to put your SFC ID number into the chat. I know that's like the usual drill. I'm just gonna keep a note of how many people are here just to let like Miss Boyd know, but this is not one of the group sessions, so thankfully I don't have to keep track of that today. Um, but okay, so like I said, I have your outline, I have like access to everything, so I know at least what chapters you're doing. So I picked questions that were specifically teetered towards like the chapters that you had for your MedSurg outline. So the first like questions that I have is for respiratory. So the way I would like this to run is that I'll read the question, I'll give you like a minute or so to answer it, and then everyone can like type in the chat or just shout out like what answer they chose. And if they would want to put why, they can too. Does that sound good for everybody?
Yeah, that's good.
Yeah, that's fine.
Yes, thank
Okay,
you.
awesome. Okay. So the first question I have is after suctioning a tracheostomy tube, the nurse assesses the client to determine the effectiveness of the suctioning. Which findings indicate that the airway is now patent? I'll give you like a minute to answer. When you have your answer, you could just type it in the chat or say it out loud. That's fine too.
Would it be B?
Yes. Um, So the reason that the answer is B is that all of the other options, if you were looking through them, they weren't signs of a good airway clearance. There was some sort of problem. They had pallor, they had restlessness, they were using accessory muscles. None of that's good. And the question was pretty much just asking like which one would be a normal and good finding. The other ones would not be normal. And this is the rationale. Obviously, we want respirations between 12 to 20. All of the other ones, like I said, indicated an abnormal respiratory status. Okay, so we can go to the next one. This is a client on a long-term mechanical ventilator becomes very frustrated when he tries to communicate. Which intervention should the nurse perform to assist the client? Okay, so I'm seeing you put a lot of answers into the chat already. Um, so yeah, the answer is D. So when we want to
I'm
think
sorry,
about,
Alicia.
hmm,
I just want to know, are you going to make this video available to us once we're done?
yes,
Okay, perfect. Thank you.
you're welcome. And like I said, if you need access to the slides, like to review it after or like have them, just like let me know.
Amazing.
Okay, but yeah, it seems like everybody put D. That is the correct answer, and the rationale is that writing and using a picture board or spelling words would be a more appropriate response, especially because we always want our patient to feel like we're in control. All of the other options would be like non-therapeutic, and they would not really help this patient. So definitely it would be choice D. Asking the physician to take them off the ventilator wouldn't make sense. Having a family member interpret, we never want to do that. And we never want to assure a patient that everything's going to be okay, because that's definitely not the case. Um, but okay. So here's the third question. Third question is a nurse assesses several clients who have a history of respiratory disorders. Which client should the nurse assess first? So this one's definitely a little tricky because they all have a history of respiratory disorders. And we don't know what kind, but we know that they have a history of respiratory problems. So actually, A, B, and C would be normal. It would actually be D because a heart rate of 120 beats per minute is not normal. Tachycardia could indicate that they're having hypoxemia or lack of oxygen to the tissues. Um, and a barrel chest or an oxygen saturation of 92 or orthopnea are normal findings in a situation where these patients have a respiratory disorder, but the one that was most concerning would be D, just because of the fact that besides having a respiratory problem, now they're having a cardiac indication. So that could mean there's something going on. Okay. So here's question 4. A nurse cares for a client with arthritis who reports frequent asthma attacks. What action should the nurse take first? Okay, yeah, the answer is B. Because here's the thing, the key word was that they have a history of arthritis and now they're having more frequent asthma attacks, right? So if they're becoming more frequent, we're wondering, maybe it's something that they're taking because they might not be using like a bronchodilator. We don't really know exactly their history, right? Reviewing pulmonary function tests wouldn't really be appropriate. And requesting arterial blood gases wouldn't also be appropriate in this scenario. And NSAIDs, which are usually, given for patients who have arthritis, could actually increase inflammation and cause more frequent asthma attacks. And another thing that might help is like we always want to pick when it comes to what to do first, most of the time an assessment. Unless it's an emergency, then we might have to notify the provider or call a rapid response team. But if there's a choice that says, hey, like assessing the patient, looking at their medication history would be a way of assessing the patient. And also like looking at their use of bronchodilators wouldn't address the reason why they're having attacks. The bronchodilators help either prevent attacks or open up the airways when they have an attack, but it's not going to be the cause of them. Okay. So the next question I have is after teaching a client who is prescribed a long-acting beta 2 agonist medication, a nurse assesses the client's understanding. Which statement indicates that the client comprehends the teaching? So this is a hard one, but we're talking about a long-acting beta 2 agonist. So only the short-acting drugs, such as albuterol, are used for asthma attacks. So we would automatically remove B, right? And that would also automatically remove A because only a short acting we would carry around if we need it, because that's when you use it if they're having like an asthma attack. The answer would actually be C, because you would take it every day around the same time to prevent an attack before it starts. It's more for long-term use. That's why it's so interesting with med-surg is because everything ties in. A med-surg question is easily a pharmacology question because it all relates. So this is the rationale. Like I said, it won't prevent like an asthma attack when it's happening. It won't stop it. It will prevent future attacks, but this is for long-term maintenance. And you never just take this medication, like I said, during an asthma attack because it won't have an immediate effect. It'll take much longer for this drug to work. And the last choice, you never just stop taking a medication when they feel they no longer need it. No. So the answer is C. This is like a two-part question. So, this one is that the nurse evaluates the following arterial blood gas and vital sign results for a client with COPD. So just take a minute to look at this. If you want, take a picture of it, and just someone like, at least if a couple people say in the chat like, "I'm ready," or hit next, and I could show you what the question says. So the question, based on the data, is what action would the nurse take first based on the previous data? Yes, the answer is D, right? The most concerning data out of all of this was that looking at this information is that they really have a high CO2 level and they have a really low oxygen saturation. Even for a COPD patient, it could be in the 80s, but it should never be in the 70s. So our first thing when it comes to like airway breathing and circulation, our ABCs, we want to make sure that we give them oxygen. All of the other options would not help this patient. Here's the next question. This is a select all that apply. A nurse teaches a client who has COPD, is teaching them education points. Which statement relates to nutrition would the nurse include in this teaching?
This one's kind of complicated.
That's okay. Definitely, I think a lot of things can be very confusing, but here's the answer. So the answers are A, B, D, and E. So just looking at them, right? Drinking fluids right before or during meals might imagine this, they're drinking and eating, drinking and eating. That could be really hard for them, especially when their oxygen's a little lower. So we wouldn't want them to do that, okay? Definitely B, right? Resting before meals because it could take a lot of energy from them. C doesn't really make much sense. You do that normally, but doesn't really relate to the teaching of COPD. Pursed lip breathing is always a technique that we use for our COPD patients. And a high calorie, high protein, soft diet would be good to make sure that they are easy to take in and they're less tiring. Okay. So the next question, which I believe is the last question on respiratory, is a male client is admitted to the healthcare facility for treatment of COPD. Which nursing diagnosis is the most important for this client? Okay, so I see a lot of answers flooding in already. And yeah, it's D. Um, no, that was not a select all that apply. That was which one would be the most important out of all of them. Uh, but they're all technically correct. They're all great choices, but impaired gas exchange related to retained secretions, that means that they're having a problem obstructing their breathing and their airway would be the most important one out of all of the options here. So they always say the rule of thumb is those ABCs or airway, breathing, circulation. And this is a respiratory problem, so we're looking for, of course, if it's present, a respiratory like nursing diagnosis. Okay. So that's it for respiratory. Now I'm gonna go into cardiac. Um, but I hope these are like useful. I tried to take, like I said, ones that could relate because anything can be asked because when you look at NCLEX questions, they combine everything. There's no such thing as med-surg pharm and patho when we take the questions. And med-surg is definitely one of the classes that combines everything. But now we're gonna talk about cardiac. Okay. So the first question is a telemetry nurse assesses a client who has a heart rate of 35 beats per minute on the cardiac monitor. Which assessment would the nurse complete next? So for this question, the answer is actually C. This is because if they're having a heart rate of less than 40 beats per minute, um, they could be very dizzy, right? They may be losing perfusion to the brain. So we want to see, are they alert and oriented, right? Are they confused, right? What's going on? We want to see their actual like neurological status. Even though pulmonary is always something that we usually think to do first. In this situation, there's no indication that they're having a respiratory issue. All we see is that their heart rate is 35. So we want to go to them and like assess them, right? Are they verbally there, right? Are they going into like a comatose state? We don't really know what's going on. So our best is to see how they are alert and oriented. Um, Definitely a tricky question, but I wanted to put questions in that would get you all thinking. Okay.
Wait, Alicia, I have a
Mhm.
question. So if the patient is having tachycardia and is loss of consciousness, what about if they're having bradycardia? What would that be?
So is your question is what would we do if they're having
Yeah.
bradycardia? So like I said, in this situation, if they are alert, that's good. Okay. So we'll try to give them medications to increase their heart rate. We could give them, I believe if they have bradycardia, we can give them albuterol. We can give them that to increase their heart rate. And if they're like unconscious, we give them like cardioversion to like wake them up. We could also give them atropine for bradycardia. That's usually the drug of choice, atropine, like 0.5 to 3 milligrams, because that's a anticholinergic or a sympathomimetic drug, which will increase the heart rate. And if they're really, really bad, we'll cardiovert them to like really get them up if they lost all consciousness. So those are like the two things. So medications or cardioversion, like, and that's really what we do. So probably though, hopefully this person was alert and oriented and we could just give them atropine and move on with our day. But yeah, those are the two things that we would do. Okay. So the next question is a nurse assesses a client with tachycardia. Which clinical manifestation requires immediate intervention by the nurse? Okay, yeah. The answer is A, okay? if a client has tachycardia and they're having chest pain, even if they have tachycardia, that doesn't matter. That was just to trick you. Out of all of these, which one would be the most scary? And it would be chest pain because they might be having an MI. So sometimes they throw in things to trick you, and it doesn't really matter if they're having tachycardia or whatever. But if they're saying, hey, I have chest pain, they might be having a heart attack. So yes, the answer is A. Okay. Now, this is a select all that apply question. This is a client with chronic AFib is being discharged on warfarin therapy. What discharge instruction is the nurse required to provide? Okay, so I'm seeing a lot of answers flood in. Now, good thing with select all that apply is that you get partial credit, right? Based on what answer choices you do pick. But the answer was A, C, D, and E. So this is about a medication, right? Med surg can be a medication question. That's why I always say it's so important to know your meds, because this is a very could be a very likely question, right? So first is dietary restrictions. Why? They can't have anything with vitamin K. Vitamin K is the antidote, right? They need close laboratory monitoring because their INR needs to be between 2 and 3, right? That's that clotting factor. Um, Always we want to tell our patient are any drug-drug interactions and the reason to take the medication. So like even if I didn't know dietary restrictions, I definitely probably would have picked D and E. And follow-up laboratory monitoring sounds like a decent answer, even if I didn't know what this drug is, but I know it's an anticoagulant, so I'm going to have to be looking at some like lab values, so definitely C. And A, because like I said, they can't have any green leafy vegetables because of vitamin K is the antidote. Okay, so here's the next question. A client has hypertension and has high risk factors for cardiovascular disease. The client is overwhelmed with the recommended lifestyle changes. What action by the nurse is best? So, all of these are very, very good answers, but the answer is actually B. That's because they are overwhelmed with all of the changes. So our goal is to first get them to do one change that is comfortable for them that they can control. They definitely could have stressors in their life, but the problem in this, or the key thing to look out for, is that this client is overwhelmed with the changes that they're being told to implement. So the best thing that we can do is try to find one thing that they can change and the client can control, right? So like, hey, let's start off with what sorts of foods, would you be interested in trying, or what can we do to like supplement the diet, right? Because they're just hearing a lot of maybe lifestyle changes, but all of them are great answers. But the stressors is not really what's going on in this question. They definitely could be stressed with things, but the main thing is that we want to find we want to give patient control, because when patients feel overwhelmed with changes, it's usually because um they feel like they're not in control. So we can start off by only looking at one thing that they can change. But all of them are really good, but they're not going to help the client with their feelings of control. Okay. Here's the next question. A client is receiving an infusion of alteplase for an intra-arterial clot. Okay, alteplase is one of those clot busters. Okay, the client begins to mumble and is disoriented. What action by the nurse is most important? So this one is a little tricky, but the answer is B. This is because, right, we just gave them a medication, right? We're infusing a medication, and all of a sudden now they're becoming disoriented. That means this medication is having some sort of adverse reaction with the patient. And even though we want to assess the client, we do, but this client became just mumbled and disoriented after taking this medication. So we want to get the rapid response team here because we don't know what's going on. They might be having a stroke. They might be having a respiratory or an airway occlusion. Something might be going on with this patient. So notifying the rapid response team would be the best. We can assess the neurological status while we're waiting for them, but they could be having a hemorrhagic stroke, right? Because the clot buster and alteplase can cause, right? It causes the clot to like burst, all right? So that causes a high risk of bleeding. So we really need to get the rapid response team because there's a significant issue. And if they determine that this client is having a hemorrhagic stroke, we need to do interventions immediately. So an assessment wouldn't be the priority, even though it is a good answer. It's not the best. And vitamin K is only the antidote for warfarin. So this is definitely a hard one, but this is one of those situations where if it says like they're taking a medication and they're becoming disoriented, or there's like a rapid change in status, I would pick either notify the provider or that, because assessing them might not be the best thing considering that this could be a rapid deterioration of the patient. Okay, so here's the next question. A nurse is caring for a client with deep vein thrombosis, or a DVT. What nursing assessment indicates that an important outcome has been met? So, for this question, the answer is B. Here's why. This is where everything gets a little crazy in terms of you have to understand the disease and what can happen. So in DVT, we can have a pulmonary embolism, right? So the clot can go to the lungs. So if they're having an oxygen saturation that's still 95 to 100, they're not getting that clot in their lungs. That's good. That means our interventions is working in order to prevent, because if they get a DVT, our goal is to prevent a pulmonary embolism. So we're looking for a respiratory answer. And the only one that would do that would be an oxygen saturation of 98%. The pain is good if this was a pain question, if they asked them about management of pain. Ambulance with assistance. Usually with DVT, we don't want them to move too much when they actually have it, because it could actually make the clot move. We want them to ambulate before, but yet the problem is that, like I said, they're at risk for pulmonary embolism. So out of all of them, The answer was oxygen. And even just like I said, a rule of thumb, the question was kind of asking like what was the best outcome. If I didn't really know, I'd probably pick something that has to do with respiratory. But in this situation, it's because a pulmonary embolism or a clot in the lungs is a high risk factor when someone has a DVT. So here's the next question. This is a select all that apply. So there's more than one answer, maybe. But a client has been bedridden for several days after a major cardiac surgery. What action does the nurse delegate to the assistive personnel for deep vein thrombosis prevention? Remember, as a nurse, we can delegate tasks to other people, but there are certain roles that we can do that they cannot. So think about that when it comes to what can I delegate to an assistive personnel. Remember, they're not a nurse. I'll also give you another hint. When you look at a question like this, the DVT, yeah, that's great, but it's basically just asking what can an assistive personnel do? What are they allowed to do out of all of these tasks? Which ones can they do? Okay, so everyone seems is on a really, really good track. Oh, did I not put an answer to this? Oh, I had one, but I don't know where it went. I'll edit it at the end. But the answer was A, B, and D. I think I might have accidentally deleted it. But it's also D because that's something they can do. The question, sometimes these questions like to trick you. And they're like, oh, DVT prevention and blah, blah, blah. They had a cardiac surgery. That really doesn't really matter. The question was more or less asking what can an assistive personnel do? And they can apply compression stockings. They can assist with ambulation. They do not encourage coughing and deep breathing. That is a nurse. We educate that. And they do not teach assistive personnel. We are educators. We teach patients exercises. But an assistive personnel can also offer fluids. Sorry about that. I don't know where that answer went.
Hello,
Hmm,
Alicia.
yeah.
Hello. I know
Can you,
when it comes to after surgery and the patient is bed rest for like days, it is the nurse responsibility to first take the patient for a walk. And if the nurse makes sure he's steady on his feet or on her feet, then they can tell the AP to assist now. But the patient has been bedridden for days. He hasn't gotten out of bed at all. So I think, I don't know what, that's what I see in the hospital. So that's what I'm applying that knowledge here.
I know what you mean. See, the thing is, this is like, that's the thing. The question is trying to trick you by giving you all of this information. The question is not really caring so much about that they had the major cardiac surgery, that they're trying to do deep vein thrombosis prevention. All the question is asking is what can an assistive personnel do? Like I said, I'll get the answer for that in edit. I knew it was A, B, and D. And that's just because these are tasks that they can do. All the other stuff was there to trick you. Like I said, you said, you're thinking in terms of the hospital, and that's really, really great. But this question is more or less just saying, what can an assistive personnel do? Everything else is just fluff. And that's sometimes what you have to look into these questions. What is the question really asking? So, yeah. And like, because they also had a surgery, we always want to get them ambulating as soon as we can. And an assistive personnel can do that. They can assist with ambulation, even though they've been bedridden. That's just there to trick you. But like I said, I'll get the answer. I'm like 99% sure it was A, B, and D. I don't know what happened to it. Okay. So here's the next question. Which is the primary consideration when preparing to administer thrombolytic therapy to a patient who is experiencing an acute myocardial infarction? Okay, yeah. The answer for this question is D. That's because like thrombolytic therapy needs to be given within a certain time frame, usually within 12 hours for an MI, and if we're talking about a stroke, it's usually within 3 hours. So that's why our primary consideration is when did these symptoms occur. That's going to let us know, can we give this thrombolytic therapy? Is it going to be effective? And yeah, that could also tell us a lot about the MI itself, and what could have triggered it. Okay. My last question is a nurse is assessing a 67-year-old patient who has a history of left-sided heart failure. Which of the following signs and symptoms are associated with left-sided heart failure? Select all that apply. So everyone's on a great track, but I see one missing, and it's actually B, C, D, and F. That's because when you have left-sided heart failure, right? I'm happy everybody remembered respiratory, lungs, so anything that had to do with cough or breathing issues were definitely all the choices, right? Like the crackles, the dyspnea, the cough. But the problem with left-sided is that the kidneys take a lot of the perfusion, and if the left or the ventricles are not able to push out the blood to the rest of the body, it's not also getting to the kidneys, which means that we have oliguria or decreased urine output because the kidneys aren't being perfused as well. So it's basically pulmonary and the kidneys when we're thinking about left-sided heart failure. Now, this question could trick you and say they had congestive heart failure. Congestive means they have both right and left-sided heart failure, or bilateral heart failure. The answers would be everything. So just keep that in mind. If you see congestive or bilateral heart failure, all of the answer choices would have been correct. But since we were talking about left-sided, the answers were B, C, D, and F. Okay. So now we're going to talk about immune. I know you have like 5 immune questions on here, so I grabbed a few. So the first question is that a nurse is assessing an older client for the presence of an infection. The client's temperature is 97.6 degrees Fahrenheit. What response by the nurse is best?
Alicia, are you speaking? Because we can't hear you no more.
You didn't hear me at all, what I said before?
I can hear you.
Oh,
Oh, okay. I got nervous. I was like, is my mic? I'm using my headphones. I just read the question. Did you hear me read the question? Yeah, all I did was read the question and then I muted myself. But let me come closer to my computer just in case that's the reason why. But oh, sorry. But the answer for this question is A. Because one, with older adult clients, they might not always present with a fever. Two, we don't really know what kind of infection they have. So just because they don't have a fever doesn't mean they don't have an infection. So a rule of thumb would always be if there's an answer that says assess, I would pick the choice that says assess the client for more specific findings or assess the client for X, Y, and Z. Because documenting the findings would indicate that this is normal and the findings here would that could potentially harm the client because we're not fully assessing them. So the answer is A. Okay, so the next question is, the nurse assesses clients for cardinal signs of inflammation. Which signs and symptoms does this include? Oh, I forgot to say, this is select all that apply. So the answer is A, D, and E, because the signs of inflammation include redness, warmth, pain, swelling or edema, and decreased function. We do not typically see pallor in someone who has inflammation. Pallor means like pale, so we don't typically see that. But we do see redness, warmth, and edema, and we wouldn't also see pulselessness.
Alicia, for edema, I was thinking like, edema. So edema is the same as swelling or?
Yeah, in this situation, it's not necessarily mean like I mean, swelling would still in edema. Edema is another way of saying swelling, right? But edema, we think of like the fluid buildup, but this simply just meant like swelling in this question. But I definitely see what you mean. That could be really tricky, but edema does just mean there's swelling. Okay, so the last question I have is a little lengthy one for immune, is that your patient is started on an IV antibiotic to treat a severe infection. During infusion, the patient uses the call light to notify you that she feels a tight sensation in her throat and it's making it hard to breathe. You immediately arrive to the room and assess the patient. While auscultating the lungs, you note wheezing. You also note the patient is starting to scratch the face and arms, and on closer inspection of the face, you note redness and swelling that extends down to the neck and torso. The patient vitals are the following: blood pressure 89/62, heart rate 118 beats per minute, and oxygen saturation of 88% on room air. You suspect anaphylactic shock. Select all the appropriate interventions for this patient. So this is a select all that apply. Yes, I love seeing that everyone's putting their rapid response team, right? This is another situation where that comes in. Yeah, so everything but A, because A, we want to stop the antibiotic. We're not going to slow it down. We want to call the rapid response team because their airway, right? It's swelling. We want to place the patient on oxygen, and we need to give epinephrine for anaphylactic shock. So there's our little pharmacology, right? Knowing what medications treat what. So I love that everyone put that. Okay, so we're done with immune. The next thing I have is GI practice questions. I don't know if we're going to be able to get through all of them today. Like, I'll see how many more people are joining. If when it hits 6, if people want to go over patho, I will have to stop the questions and I could share it with you all after. But I hope these are being useful because they are practice med surg questions. But yeah, I'll just see what everyone thinks if more people start to join. I haven't seen anyone else join yet though so far. Okay, so here's the first question. The nurse is planning to teach a client with gastroesophageal reflux disease about substances to avoid. Which items should the nurse include on the list? Okay, so like I said, this question is related to GERD, right? Even if this isn't like patho or we're talking about med surg, everything's the same. And this could even, if GI was on your patho final, right? It would be what can I give for GERD? What food should I tell them that they should avoid? And it's A, B, C, and E. So basically all of those foods, coffee, chocolate, fried food, peppermint, they all aggravate the esophagus, as well as carbonated beverages and alcohol. Those are the ones we would tell them to avoid, and peppermint also. Everything else wouldn't really, like non-fat milk or scrambled eggs wouldn't bother the patient. I know some of you do have a review at 6, so if you have to go, you can. I'll definitely see what everyone else wants to do after these questions, if they want to continue it or ask some patho questions, because I know I said at 6 I would do patho. Okay, so the next question is that a client with a hiatal hernia chronically experiences heartburn with following meals. The nurse should plan to teach the client to avoid which action because it is contraindicated. Don't think about the hiatal hernia. Like I said, these sometimes they try to confuse you, right? What should I do for a patient, right? If they're having heartburn, which one of the following should they not do? Yes, because heartburn, right? If they have heartburn, laying down after they eat, especially, is going to make it worse. So all of the other ones were great options, right? And yeah, with the hiatal hernia, it's the same sort of thing. Even with any of these GI things, right? If they're having some sort of heartburn from reflux, we never want them to lie down after meals. So that's a rule of thumb. Okay, so I can't see this because my thing is blocking it, but I think it says that the nurse is, I can't read the top part. So the nurse is monitoring a client admitted to the hospital with a diagnosis of appendicitis who is scheduled for a surgery in 2 hours. The client begins to complain of increased abdominal pain and begins to vomit. On assessment, the nurse notes that the abdomen is distended and bowel sounds are diminished. Which is the most appropriate nursing intervention? Yes, okay, I'm seeing a lot of A's. Yes, right, you're catching on quickly. If there's a sudden change in status, if it says notify doctor or, rapid response team, I would pick one of those. So yeah, the answer is A, based on the symptoms, based that they have appendicitis, now they're having increased pain and they're beginning to vomit, something's going wrong and we need to notify the doctor immediately. All the other options would not be appropriate for this scenario. Okay. Now, okay. Here's the next question. The nurse is providing dietary teaching for a client with a diagnosis of chronic gastritis. The nurse instructs the client to include Which foods rich in vitamin B12 in the diet? Select all that apply. Okay, yeah, everyone's on a good track. So it is A, C, and E. All the question was asking is which ones have B12 in them, and other foods include right nuts, organ meats, dried beans, citrus fruits, green leafy vegetables, and yeast. Now, I know that some of you have to go for patho, but I wanted to ask, do you all want me, whoever's going to stay, do you want me to continue with these questions, or do you want me to move on to patho or farm? I'm just asking because I want to do what's best for everyone. And yeah, I don't know. Could I do a poll on this thing? Here we go. I can create one. So I could ask you, I'm just gonna put, oh my God, continue questions. Oh, all right. All right. I think I just sent a poll. I have no idea what I did, but did you get it? Um, I don't know what I did, so I hope it worked. But if you need to go, like I said, go definitely go to your professor. But if you're planning to stay and you'd like me to continue with these questions for whoever is here, just let me know. There's not too much left, but it should help with, med surge if that's all what you want to do. I don't know if you've all received the poll. This is like the first time I've ever done that, so I don't know if I did it correctly. But would you all like to continue, or would you like to do patho? If there's a lot left, okay. So, I see there's 1, 2, 3, 4, 5 people left. So I did promise that I would go over patho at 6, so I don't want to astray from that. I don't mind going over patho if you have like specific questions, since I don't have like access to your content. But we could always go back to these after I answer any of your questions. I'm really fine with whatever you all want to do. I just kind of want to do what's best for everyone. So do you all want to continue the questions, or would you want me to help you with some of the patho stuff? It's up to you all. I can't see. I don't even know if I shared a poll because it's gone now, I think. But yeah, so what do you all want to do? Do you want to continue? Or do you want me to start going over patho, like answering your questions? I see one and somebody said patho. So if nobody says anything else, then I'll stop this. Oh, I see. Sorry. I didn't see that. Okay. Okay, yeah. So we could definitely go over patho. So I'm just gonna stop sharing. Okay, like I said, I don't have access to any of your slides. So I need like specific questions. So I know like how to help you. So what sorts of questions do you have about patho for your final? I don't know if you have an outline. Somebody could text me it or put it in the chat or something.
I'll try to find it, but for Nancy, she kind of gave us like a really like vague outline. So let me see. I'll send you what she sent us.
Okay, thank you.
Maybe I'll have something else for Nancy, but all I have is her like. Oh, wait, this might be for farm. Wait, 1 second, sorry.
It's okay. I just don't have anything. So, anything that you have that you all want to go over. I think everyone in here is in Balkan, so that should Dr. Balkan's class, so that should help.
Are you able to go over like the sensory disorders like hearing and vision?
Sure. Do you have like specific ones? Because I'm gonna have to find them in my notes, which might take a little bit. But I have them, so let me see if I can find sensory. Okay, sensory. Are you talking about, oh, I see, I got pictures now. Okay, people are sending things. Okay. Okay. I have your notes now. Okay. So the thing is, I'm seeing with your notes is that a lot of it does interplay with MedSurg. But let me see with the sensory. Okay. Let me share my screen so I could do both at the same time. Okay. So I'm trying to look for like the sensory like disorders because okay. So she said cranial nerves, extrapyramidal, and I don't see any sensory disorders on here. Do you have like a specific one? Because I don't see on the outline. It just says cranial nerve, extrapyramidal, and pyramidal motor systems, and then it goes into motor disorders. Because I'm not seeing that in so you all have sensory. Is sensory going to be on the final?
Yeah. So she
Okay.
said, let me see, sensory, motor. She said we should know the cranial nerves.
I sent you on the outline that she gave to us.
Okay. Yeah, I'm seeing the picture now because I have two different outlines. That's why I'm getting confused.
She also I'm also confused in general with what this test's going to be over because she sent like 3 things, so I don't know exactly what it's on because she's confusing sometimes.
Okay. Well, because two people sent me two different things. That's why I'm a little confused too. That's why I'm trying to look at everything. Okay. So I did see on something that somebody sent me. Oh, that's for Kassler. Got it. That's why I was confused. Okay. That makes sense now. Wait, Alyssa, Dr. Kassler is having a review right now for Patho. That's what I heard, that she's doing a review right now at 6:00 for Patho, if you want to join that. I don't know, unless she's not doing it
No,
anymore.
because some of us have Balkan and we don't have the same quizzes, final. So maybe those who want to join Kassler for her class, sure, but we have Balkan, so.
Yeah, but there's one person in here who has Kassler. That's why I mentioned that. That's why they sent me Kassler. But I know Kassler's having a review right now. That's why I said that. But okay. So I can go over sensory. Let me just, I'm gonna get that slideshow that I was just sent because I could now I know what you guys are all doing. But yeah, if you have Dr. Kassler, I think one person does. She is doing a review right now, so I would highly suggest going to her review. because she knows like what she wants you to focus on and that's what she's doing. I don't know where it is, but I would go to that. Not in a mean way, but I just know that she's doing something and I don't want you to miss out on that. Okay. So now I have what I need. But okay, so I'm getting everyone's notes for Balkan. Thank you for that. Like I said, I get a little confused because I don't know what goes on. But okay, when I went over this when I had Dr. Balkan, um, she didn't get too like in depth with it. I definitely know that I would know like basically the basics. Like I wouldn't get too into it because I know like when I had the questions, it was more or less just about like the foundations of everything. I don't remember her ever giving like really specific questions on any specific like disorders. Um so let's see. So you know that when it comes to like sensations, we're talking about pain, touch, pressure, temperature, uh proprioception, which is like your balance. And then we have special senses, which is our taste, our smell, our sight, our hearing, and our balance. We're going to be looking at like different sorts of disorders and things that are going to relate to that. So we have, I would definitely know the types of receptors. So for sensory receptors, we have mechanoreceptors, which basically have to do with our pressure and like really forceful touch receptors. We have chemoreceptors, which are activated by chemicals like blood or food or air. Thermoreceptors, which control our temperature, heat, or colds. Photoreceptors, which are activated by light. And nociceptors, which basically deal with pain. I would definitely know these. I could definitely see Dr. Balkan asking you about this because she likes the foundations, and these are pretty like fundamental points when it comes to sensation. So pain, we know, can mean a lot of things. And something that's really important with pain is that we have a pain threshold, which means that there's a certain level of pain and a perception of pain that's sensed. So let's just say, like, I feel my pain is a 5 out of 10. That's my perception and level of pain. And different things can influence that, like your behaviors, your mood, your cognitive status, things like that. But if we have unrelieved pain, that can cause a delay in healing. It could cause us to be more stressed, and it could even result in tolerance to pain. So if we're getting so used to that pain that we might not know, let's just say if we cut our foot, but we're so used to cutting our foot in the same spot that we don't even realize we cut ourselves. That's what tolerance means. You have to experience more of it to actually feel it more, which can be, very scary. So I would know the different types of pain, like somatic, that it runs through the skin, the joints, the muscles, and they're usually in like specific locations. Whereas visceral pain is usually in organs. You don't really know where. It's hard to tell exactly where it is, but sometimes they call it referred pain because it usually affects areas distal or different than the area. So let's just say you feel like you're having pain in like your liver, you might not feel it like in your lower stomach. Maybe you feel it in like your shoulder. That's what it means by referred pain. I would definitely know, like I said, the different types of pain. That phantom pain is the pain that you experience when you remove a limb, right? So if you just had a surgical procedure and you removed your foot or something. Intractable pain, which is basically chronic and it doesn't go away. It's very, very debilitating, and it doesn't really respond well to pain management. That's something I would know about intractable pain. And that neuropathic pain results from damage to nerves, right? Neuropathic. And one of those diseases that can cause neuropathic pain or neuropathy is diabetes mellitus. So, pretty much, I don't remember Dr. Balkan ever asking about the different structures of the eye, but I don't even think that's on your outline if I'm correct, right? I don't see anything that says what the eyes do or what the ears do, just the hearing or visual disorders. Is that correct?
Mm-hmm. Yeah.
Okay. So I would like read over this to know like what each part does, right? But the whole point of your eyes and all of these different parts is to help you see. And we're going to see different parts that different visual disorders that are going to affect different things. So like there's going to be something called retinal detachment, and we really need our retina because they have the rods and the cones, right? The rods are for the low lights and they function more at night, and those cones help with the bright lights and for our ability to see color. We have that optic nerve, which doesn't have any of those photoreceptors or those light receptors, and it's insensitive to light, but we need the optic nerve in order to be able to see. And usually when we see things, they are cast upside down into the retina, and that lets our brain be able to see the image. So we're going to talk about different things, right? Like aqueous humor, that's one of the parts of the brain, not the brain, the eye, that's like liquidy, and it provides nutrients, and it removes waste, but it can be damaged, and that can be an issue. So I definitely want to get into the hearing and eye disorders. I see that that's what you have. Disorders of motor function. I'm trying to get to those things. Okay. So I think this is where Balkan's more or less going to start getting some of her questions. So, right, we're going to look at congenital or born sensory disorders. So we could have congenital eye conditions like congenital cataracts, which can cause like your vision to be very blurry, and it can cause everything to have sort of a glare, so they can't really have bright lights on their eyes. And the ears, we could have absence or malformation of the ear. So if we have, like I said, congenital cataracts, there's a clouding of the lens, and the lens is one of the parts of the eye, like I said, that helps us see, right? So it results in like a little hazy, blurry vision. And that's what I would know about it, right? So it's cataracts, and it can cause a hazy vision, but it's congenital, right? So it's present at birth. Other manifestations can include, right, failure to be able to see what's going on around you, nystagmus and strabismus, which are different eye movements. So I just need to double check what they are. I can't think of exactly what they are in my mind, but let's see, nystagmus. I just want to make sure. So this is when we have involuntary eye movement, sort of like rapid eye moving, like up or down, left or right in a circle. And strabismus is when we have almost like a lazy eye, where like the eye sort of is crossed. So and that's because the eye has poor muscle control. So we also can have amblyopia, and amblyopia is when we have the lazy eye. So amblyopia and strabismus can be sometimes confused, but strabismus is more of the cross eye, and the lazy eye is more when it just stays to the side. We usually see this though in like your childhood development, and there's something wrong with those nerve pathways in between the brain and the eye. They're just not coordinating, and this can cause visual problems. I would know the differences in between those three terms because I could definitely see her asking you about those. Okay. So, I've never seen any of these terms before with these congenital ear conditions. I'd never heard of them. I don't think she would ask you about these. I really think she would ask you about like the really main ones. And I don't see this. I would think like audius media, right? Or like those infection in the middle ear. Those are the type of things that you see a lot. I would read these over, but I wouldn't focus on them. I focus on more of the ones that you see more commonly. So another thing that I think is really important to know is that when you're aging, right, your eyes become less and less able to distinguish little details, right? So as you age, your sensory input sort of decreases, and you need more stimulation in order to get some sort of sensation. And age-related eye changes can start as early as 30 years old. But just know as you age, right, your visual acuity starts to decline, okay? So this is just some of the things that can happen, right? The lens can become more cloudy, the pupil size could decrease, the corneas can become less sensitive, but I would know the term presbyopia. Presbyopia means difficulty focusing the eyes, but it's normal. That means normal age-related decline in vision, okay? That's what I would know. I would know that term. For any sensory condition associated with aging, we can give glasses or contact lenses or things like that, or even red lighting. But like I said, I would know the term presbyopia. Now, presbycusis, right, means normal age-related hearing loss. I would know that term. Just know that as you age, your hearing declines. You don't need to know too much more than that, okay? That's what I would know. So sensory changes, right? Vision decreases or presbyopia, and hearing decreases or presbycusis. So a lot of things, right? It could be impacted crewman or earwax. It could be some sort of sensorineural hearing loss or conductive hearing loss. It could be, anything. I would also know what tinnitus is. That tinnitus is ringing in the ears, okay? And we can also get that if they have like a medication adverse reaction with like furosemide, okay? But tinnitus can be very common in our older population, and that is ringing in the ears. I would know that. Now, these are the things that I would know in terms of eye disorders, right? Cataracts, glaucoma, all that's like normal. I would know that too. But I would definitely know these, right? So, infections or inflammatory sensory disorders like conjunctivitis or keratitis, and ear infections like acute audius media or audius externa. So conjunctivitis is inflammation or infection of the conjunctiva, which is that sort of white part of the eye, right? And it can be caused by viruses, bacteria, allergens, anything that can irritate it, or it could be an infectious process, right? So it can cause pain, edema, or blurry vision. I would know that with viral infections, they normally produce more of a watery mucus-like exudate from the eyes, or bacterial infections would usually cause a yellow-greenish coloring. So that would be good to know in terms of what's going on with the patient, what kind of conjunctivitis do they have. But the presenting symptoms will be similar in terms of that redness and inflammation, the blurriness of the eye, but viral has more of the watery and bacterial is more yellow-green. Now, allergens are going to produce redness, itching, excessive tearing, right? And like making your eyes really watery. That's a part of conjunctivitis. But risk factors, I would know this because definitely Balkan is the type to ask about this, right? Wearing contact lenses, right? Wearing them for too long can cause an infection. Contaminated makeup or certain medications can cause conjunctivitis, right? And bacterial or viral conjunctivitis is very contagious, okay? So we have to have infection precautions. And, eye exam would be a good way to give a diagnosis, and a drainage culture could let us know, is it bacterial or is it viral? But I would really know the risk factors, the difference between bacterial and viral, that allergies can also cause conjunctivitis, and then what sorts of symptoms do you expect? Treatment, it all depends on what it is, right? Is it allergy response? Then we'll give antihistamines. Is it bacterial? Then we'll give antibiotics. Or is it viral? You're not going to really give anything for viral. You're just going to have to let it, come out. And then comfort measures, right? Like warm or cool compresses, depending on what helps. Keratitis is inflammation of the cornea, and that is usually triggered by a viral or trauma infection. It can be caused by herpes simplex virus type 1, which can be transmitted from the mouth and cause an ulcerated form to the eyes. So, what are the manifestations? Well, we have pain, right? Itis means inflammation. So usually with inflammation, even when we were talking about med surg, right, we're talking about pain, redness, but there could also be drainage, excessive tearing, photophobia, which means that you have like aversion to lights, like really bright lights, and visual disturbances. Okay, so that could be distinct, right? She could say, okay, a person comes in and they're having severe pain, redness, drainage, and photophobia. That would let me know that it's keratitis because conjunctivitis doesn't have photophobia. And once again, diagnosis, right? An eye exam. And drainage culture, right? Is it a viral infection or was trauma induced? Okay, and we want to treat whatever the cause was. So acute otitis media, that's our hearing, that's our ear. That means we have inflammation or an infection of the middle ear. It's very common because those Ascasian tubes, I would know what that term is. That's where we have the air. It equalizes the air pressure in the ear. They're much narrower when you're like a baby, so you're very more common to see that. So usually it could be caused also by like fluid accumulation, or inflammation. And you'll see it maybe in an upper viral infection, right? Maybe like pain in the ear and things like that. Okay. So I would know that acute otis medius means that there's infection in the middle of the ear, and we typically see that in children because of the problem with the Ascasian tubes. So other risk factors, right? Daycares, remember, it could be like an infection, smoke, pacifier use, anything that can be like spread, right? Allergic rhinitis, because we also said a problem of that can be an inflammation. So allergic mediated responses can cause inflammation. Other complications can be effusions or fluid buildup, rupture, right? Too much pressure buildup in that Ascasian tube, scar tissue formation, or even hearing loss. Okay, so they could have hearing loss, and all of these problems. So how do we know if they have this? Well, if they have ear pain, they cry a lot. If this, a really key manifestation is rubbing and pulling at the ear, that would let me know that this child has otitis media. Okay, like I said, are they having an infection? So we're looking for any sort of drainage and things like that from the ear, as well as they can have nausea and vomiting. But I would know that ear pain and rubbing and pulling at the ear, or a red and bulging tympanic membrane. That's how we get our sound waves to travel in the ear, right back to that A and P. I would know that. So once again, if we're talking about eyes, we're talking about ophthalmology exams. If we're talking about ears, we're going to think about ear exams and cultures, okay? Because the culture is going to let us know what is it? Is it a viral? Is it a bacterial? What's going on? So depending on what it is, we treat whatever's going on. Is it inflammation? Is it the adenoids that's causing it? Is it, are they having fever? So we can give them an antipyretic, right? Is it a bacterial infection that's causing the inflammation or the infection of the ear? Then we'll give antibiotics. Okay, so the next thing is otitis externa, which is inflammation of the external ear. And this is usually bacterial in origin, but it can also be fungal. And where does it come from? Usually from moisture that builds up in the ear, right? So maybe this person is a swimmer and they're always exposed to that warm, moisture-like environment, okay? This is what we get swimmer's ear. It's also called swimmer's ear, okay? So I've had this a bunch as a child. I don't know if any of you've ever had swimmer's ear, but it's extremely painful. So this one, remember your swimmer's ear, okay? So usually swimming in contaminated waters, scratching outside the ear, irritant, you get hearing loss, pain, inflammation, things like that. The ear pain worsens when you move that outer ear, right? You could have drainage, itching, or fullness in the ear, okay? If you ever had swimmer's ear, then you know what this is. So right diagnosis, looking at an ear exam, looking at that drainage or the exudate, right? And how do we treat it, just if it's a bacterial or if it's a fungal, okay? That's how we treat those things, okay? And you know, you don't want to put anything into the ears, or you could wear earplugs in the pool. That's what I used to have to do as a kid to prevent swimmer's ear. And avoiding bathing with alcohol-based products. That's going to really irritate the ears and things like that. And make sure you keep the ear canal very clean.
Oh,
Does anybody have a
How are you?
question?
I'm hungry. I'm hungry.
Okay. So, the next thing is, right, okay, eye trauma. I don't really see that on your final outline, but I would just know that any trauma that can go to the ear or even to the eye can cause something to happen, right? Can cause hearing loss if it's ear trauma, or visual loss if it's an eye problem, right? Like a chemical burn or physical trauma, like maybe getting hit in the face. The goal or the problem that's going to occur is that they're going to have a visual deficit if it's an eye trauma, right? So they might see floaters, like, which are like little circles and flashing lights and things like that. Their pupils might be dilated or unresponsive. It really depends on what's going on. Eye pain, diplopia or double vision, dry eyes, things like that. So I would just know that if you have eye trauma, right, it can cause a visual problem. Depending on what it is, right, if it's a chemical, we want to wash out the eye. If something got into the eye, like I don't know, like a stab, someone got stabbed in the eye, don't try to remove it, you know, cover it with a sterile dressing and things like that. But I would just know for, like I said, eye trauma, it could have different manifestations, or ear trauma, depending on whatever the type of trauma it is. Just know that it can result in either permanent visual, if it's a eye trauma, or permanent hearing loss, okay? So we just want to treat whatever the issue is. Now, we have chronic sensory disorders. I definitely can see her talking about these, like glaucoma, cataracts, macular degeneration, and for the ears, otosclerosis or Meniere's disease. And they both result, the problem is that they're going to cause visual or hearing deficits. So, with glaucoma, we're talking about increased intraocular pressure and decreased blood flow to the nerve. Okay, I would know that. I would know the definition of glaucoma. Okay, so the pressure in the back of the eye becomes blocked, or that aqueous humor that I mentioned before that's in the eye will increase, and that causes the glaucoma. I would know that, okay? And this could lead to blindness. Now, there's different types. There's open angle glaucoma, which means that it's really common, but that the pressure will increase gradually over in time. And you see this more with the family history of it, or if they are African American descent. Manifestations include, right, it could be painless, but it would have an insidious onset, and there might be bilateral changes to both eyes, so blurred vision, halos, things like that, okay? And because these visual changes are very slow, we really have to be careful and not misdiagnose it for presbyopia. So if they tell you, like, hey, you know, I'm having some gradual visual changes, we should really let the doctor know that we should do a really good assessment. Closed angle glaucoma is a little different. It can be acute, subacute, or chronic. It can be caused by trauma or pupil dilation, like let's just say, you know, maybe someone had a drug overdose. That can cause extreme pupil dilation or even pupil constriction. Medications, right, like that we give for pupil dilation can also cause closed angle glaucoma. But compared to the other one, this is unilateral, so it mainly affects one eye, whereas the other one mainly affected both. I would know that, okay? But the manifestations are going to be relatively similar between both of them, but I would know the differences. This one can be one, this one can be the other, right? Open angle glaucoma is more or less, it gradually increases, but closed angle can be a little different. With congenital, just means present at birth, right? I would know that it's recessive, and it can cause photophobia, a gray-white appearance to the cornea, and things like that. Or Secondary glaucoma is from medications, but I would really just focus on open angle, closed angle, and congenital. So how do we diagnose this, right? A good eye exam. We want to look at the optic nerve imaging. We want to look at the pupil reflexes. We want to do a good retinal exam, things like that. We want to look at everything. For open angle glaucoma, these are all the medications that we can give. But I do not think, because this is patho, she's not going to test you on the medication. So I would just read these over for yourself, okay? Because once again, patho is about the idea of how the disease develops, and that's what she's focusing on. I've never had her ask about medications when I had her for patho. So, I would read these over, and then after you just read over the different treatments, I think it would just be good to know, but I wouldn't focus on it. So cataracts has to do with lens or opacity or darkness in the lens. I would know the definition of cataracts, okay? I would know the risk factors, right? Ultraviolet light exposure. So be careful with like, sunlight and things like that. Like make sure they wear glasses, right? Medications, a family history, things like that. It could affect one or both of the eyes. I would know the manifestations are like cloudy, fuzzy, foggy, color intensity loss, diplopia or double vision, impaired night vision, and photosensitivity. So they have sensitivity to light. Okay, so with cataracts, that's a big thing that they have photosensitivity. For diagnosis, once again, she's not going to ask that about that, but anything that has to do with eyes, think ophthalmologic exams. And sometimes in extreme cases, we have to remove this, the cataract surgically. Macular degeneration is one of the common like eye disorders, and it's something that you do see a lot. When I say common, I mean commonly asked about. So this is deterioration of the macular area of the retina. And remember, we talked about how the retina is so important for seeing of the rods, which like with the dark, right? It helps you see at night, and the cones to help you see color. So what happens is that there's an impaired blood supply to that macula, which results in a waste of accumulation in the eye and ischemia or lack of perfusion to the eye. And does somebody have a question? Oh no, I thought I heard something. Maybe I didn't. Okay, but yeah, so risk factors could be cardiovascular disease, hypertension. Why? Because prolonged hypertension or cardiovascular disease can cause ischemia, right? A family history, being female, and increased UV exposure, okay? So I would know what macular degeneration is. I would know this definition. Okay, so like we said, it's deterioration of that macular area and a decreased or an impaired blood supply. So I've never really been tested on the different types of macular degeneration, but I would read over it for yourself, right? And like know the difference in case she does ask. But I would know that there's two types, that there's dry and there's wet. And dry macular degeneration, we're talking about when the blood vessels become thin and brittle, and they can cause these yellow deposits. Wet macular degeneration is when the vessels actually break down and we get new blood vessels that grow underneath, but they're not as strong. So I would know with dry, like I said, we have yellow and the vessels are becoming brittle. But for wet, they're brittle, but they break down. So we try to form new ones. And it could lead to rapid vision loss, whereas dry is a more gradual process, okay? So we already kind of talked about the difference, right? Wet is a little bit more rapid and dry is more gradual, things like that. Treatment, I would just know, I would read it over, but I've never been asked about any of this. And there's no treatments. So I would know that there's no treatments that exist for dry macular degeneration. I would know this part, like, oh, what's a patient teaching point for someone who has dry macular degeneration is that there's no treatment that exists. They might try some of these things here, but there's no cure. And there's no cure for wet macular degeneration. So I would know that too, that you can't really do anything once they develop these things, okay? There's not much that we could do. We could try to provide comfort measures, but there's nothing that we could do to really help. Okay, so then we have autosclerosis, which is basically an abnormal bone growth in the middle of the ear. So I would know autosclerosis means abnormal bone growth in the middle of the ear. We don't really know why it's caused, but it causes an abnormal sponge-like bones to grow in the middle of the ear, which prevents the ear structures from vibrating in response to sound waves. Remember, we need the ears to vibrate to have the sound waves to go to our brain, for everything to be processed so that we can hear. Okay? This usually affects both ears, and tinnitus, or that ring earring, and vertigo, which is kind of like dizziness and off balance that you get when you go in high elevations, can also occur. But I would know, like I said, it's an abnormal sponge-like bone that grows. Treatment, we can give biphosphonates. Why? Because biphosphonates are also something that we see in osteoporosis, right? Which inhibits this osteoclast activity, which means that we prevent bone breakdown. So all of this has to do with bone, right? So if we're thinking about a bone, we can give them calcium, vitamin D, because that all helps with bone formation and can help promote normal bone growth, which can mitigate or control hearing loss, okay? We may have to give hearing aids, but like I said, think about it this way: osteoporosis or anything that's to do with bones, you're thinking about calcium and vitamin D. Now we have Meniere's disease, which is a disorder of the inner ear. So like I said, I would know where these disorders are, like where they work in. So all in that inner ear, and that inner ear is really important for our equilibrium and our balance, okay? So we have endolymph swelling. So what happens is that it interferes with the hair receptors in the cochlea and the vestibular. Remember, we're talking about equilibrium and being able to process hearing. So we don't know why people get this. It could be metabolic disturbances or hormonal imbalances or autoimmune, but I would know that this is a disorder of the inner ear, right? And it's causing problems with that cochlea and that vestibular, or the balance and the hearing, because those hairs are responsible for us being able to actually hear everything that was sent through that tympanic membrane. So we usually see this in ages 20 to 50. So I would also know the manifestations, that they could have acute episodes that last several months and then followed by periods of rest or relief. Attacks can be triggered by barometric pressure, meaning that if there's changes in pressure, that can trigger this, okay? So we want to be careful with elevation changes or going into high spaces, okay? So like altitude changes, such as hiking and things like that, that can trigger it, okay? And you'll have intermittent episodes of vertigo, right? That dizziness, the balance, the tinnitus, which makes sense, right? Hearing loss because of the cochlea and vestibular interplay, what they do. And I would say the problem, and know that it can cause permanent hearing loss. And yeah, like I said, you want to do a neurological assessment, a hearing test, a balance test, because that's going to tell you, hey, does my patient really have this, right? So we really need to do an in-depth neurological, but also ear exam. So here's different treatments. But remember, I would also know for this that there's no cure. It's just that we're relieving the inner ear pressure, and we could do that with anything that can reduce it, such as antihistamines or anticholinergics or things like that. Middle ear injections, hearing aids, things like that. Did she say if she was going to test you all on cancer? I don't see anything here for cancer. Like eye cancer, ear cancer. Did she say anything like that to you all?
Is it an eye disorder? We don't know, because if it's an eye disorder, then yeah.
Okay, we'll just go over them, but I don't remember eye cancers being on my exam personally. But so we could have an eye cancer, right? It can affect any part of the eye. We have melanoma, lymphoma, but most frequent is retinoblastoma. I would know that one is the most frequent eye cancer, especially in children. So it could metastasize, but remember, all of these can cause visual disturbances. So anything that has to do with an eye problem, I would know, okay, right? They can cause potential floaters, seeing flashing lights, blurry vision, things like that. But for like eye cancer, you could see almost everything, right? Loss of vision, dark spots, halos. The eye could change in size or change in movement. So we might have to do a biopsy and really good ophthalmic exams and treatment, right? It's a cancer. So we're talking about radiation surgery and worst case scenario, prosthetic eye. They might have to remove the eye. So now we're going to talk about, there's not really much for the cancer. Like I said, I would read it over, but I would know these terms because we've been talking so much about strabismus and amblyopia, or strabismus cross-eyed, or amblyopia, lazy eye, right? Retinal detachment. These are very, very common, and I could definitely 100% see you're testing you on this, as well as tinnitus and vertigo. Okay, because they're almost the manifestations of everything. So strabismus, we're talking about a gaze of deviation in one eye. Okay, so it's cross-eyed. So maybe the eye, like if somebody's looking at you, if you look in the mirror, your eyes are directly straight. But for this person, one of their eyes is slightly deviated to one side. Okay, so we can see this at birth or shortly after. The eyes can't coordinate on the same object. They can't focus on the same thing together, which results in diplopia or double vision. Okay, so I would know it's a gaze of deviation of one eye resulting in diplopia or double vision. Okay, and if what happens is the brain is ignoring the eye that can't focus on the same thing, and if that continues, the brain keeps ignoring the that eye. They can have permanent visual deficits like amblyopia, or having a lazy eye where the eye kind of doesn't work as well. So what can be a cause is that we have a weak eye muscle, all right? Or it could be a neurological deficit. So I would know the definition of it. I would know the manifestation, right? That it can result in double vision or diplopia, and what the cause is from a weak muscle or a neurological problem. Okay, could be from an eye cancer, it could be from that. She's not going to ask you about maybe associated factors. Okay, she's not so much going to ask you about the diagnosis. Once again, it's going to be an ophthalmic or a neurologic exam because it's either caused by, weak eye muscle or a neurologic deficit. But I would know what it is, okay? Same thing, I would know what this is, amblyopia, that it's a loss of one eye's ability to see details. Most common cause of vision problems. So they also call this lazy eye, okay? The preferred eye, or the eye that doesn't have the amblyopia, has normal vision. But remember, we said that from strabismus or that cross eye, if it gets ignored for too long, it can go into this because the brain ignores it too much, and now they have lazy eye, and that eye just doesn't really work. So the normal eye has to compensate for that by being stronger because of the weaker one, right? It's the same way. It's like how they say, like, if you have one sensory loss, right? Like if you can't see, your other senses become stronger. That's kind of like what this is. So since they only have one eye that's doing the work for everything, that eye becomes stronger. So what happens is that, we know the brain, right, reaches its permanent point somewhere between 5 and 10, right? So history, strabismus, it can be caused by strabismus. I would know that. And it could be family history. And that's what I would know about this. That's all I would know. I would know retinal detachment, right? It's an acute condition where the retina separates. This is asked a lot about, and we get something called floaters and halos. We'll get into the manifestations, but I would very much know what this is and what the manifestations are. Usually this occurs when the vitreous humor, which is another sort of liquid that we have in the eye, leaks through the retinal through like some sort of tear, and accumulates. So it accumulates, causing the pressure, and the retina detaches, okay? So we know that with retinal detachment, we're talking about the retina separates, right? Detachment means to remove from something. It removes from the structures of the eye because of the vitreous humor being leaked out, okay? So if there's something going on where it's leaking out, some holes, or the retina's thin, things like that. But we know it's fluid leakage, that this vitreous humor collects underneath and the retina peels away. That's what I want to know. And then what happens because of all of this, the retina becomes ischemic or lack of blood flow. It stops functioning and causes vision loss. And I would know these manifestations. So what happens is usually painless, but we have flashes of light that is indicative for retinal detachment. They could have floaters and blurred vision and darkened vision, like a curtain drawing across a visual field, okay? So I would know the floaters and that they're having flashes of light, okay? I would really know that. I would read into the treatments, but I've never really seen her ever ask about treatments. Okay. The next thing I would know, like I said, tinnitus or abnormal, hearing abnormal noises in the ear. This is ringing, buzzing, humming, whistling, roaring, blowing, but it's like a ringing sound in the ear, okay? It may be associated with presbycusis, normal hearing loss. Know that term. Can be caused by bunches of different things, right? Medications, Meniere disease, whatever. But I would know the definition of tinnitus, okay? That it's a abnormal noises in the ear, and they could be described as ringing, buzzing, things like that. So, like I said, read over the treatments, but I would not get too much into it. Vertigo, illusion of motion. It's not the same as dizziness, but it can almost feel as if it's like dizziness, okay? So there's some sort of problem with that vestibular membrane of the ear, and we're getting vertigo, okay? So it's a balance problem. Let me see if there's anything else I could find for this. But yes, so I would know what vertigo is, and understand it, that you basically feel like you have a loss of balance, okay? And you normally see this when you're looking down from a great height. So maybe she might ask, which of the following like statements by the patient would make the nurse think I have vertigo? And they feel like a whirling or a loss of balance when they're looking down from a big height, okay? That's what I would know about this, okay? And yeah. So, this is just how, right, sensations come to the eye. So we get the light, the sensory organ or the eye senses it. Those receptors convert that that light into one type of energy to another, so that it could be transmitted from the optic nerve to the brain, where the brain can visualize it, okay? I would just know how this process works. I can't really see anything really here, but I'm trying to zoom in a little bit. But I would know these this little chart, like the different types of receptors. So we have free dendrite nerve endings on the skin, which have to do with pain. We have Merkel disc, which have to do with light touch. We have pros and end bulb, which is also light touch, more in this like epidermis space. Inside the dermis, or that deeper layer of the skin, we have a Meissner corpuscle, which basically deals with touch and light pressure. Dendrites, which have to do with hair movement. We have the Panakin corpuscle, which is more deeper into the skin in that fat area, where it's for deep pressure. We have this something called Ruffini corpuscle, which is for light touch. I would definitely know these because I know Dr. Vulcan did test me on some of these like receptors. They're very common. I would know these. Let's see. Okay, I'm trying to find I'm not really seeing anything else. This is just an example of the ear, the different ear conditions that we were talking about, more in that inner ear where we're talking about the cochlea and the vestibulae, or what deals with balance, that Ascasian tube that we mentioned before about the audius medius, how everything travels, okay? Another example. this just seems more like pictures. Example of conjunctivitis, keratitis. This is where we're putting a hole in the tympanic membrane to help with hearing. So this is just examples of, remember we said glaucoma is an increase in pressure. So this is how you just kind of get a visual of how some of these different disorders work. So like I said, we have obstructions, we have increased intraocular pressure, which is causing glaucoma, right? And this is an example where of chronic open angle, where we have degeneration and obstruction of this sort of meshwork here. And in acute narrow or closed angle glaucoma, we have just intraocular pressure, but more in this canal of sclem. But like I said, I wouldn't get too much into it other than knowing, like I said, what the definitions are and then the differences. So this is how you kind of see something if you were a patient who had cataracts. This is strabismus. I remember we said strabismus can lead to amblyopia. And I would know these three charts. So the types of receptors, especially for general senses, I would know these. And obviously, you know, taste buds, sight, hearing, balance, I would know those as well. I would read, like I said, for yourself to better understand the structures and functions of the eye, but I don't think you'll be really, really tested on it other than knowing what that Ascasian tube does. I remember her asking a question on that, and it equalizes air pressure. 100% I would know what that is. But yeah, is there any questions? Hopefully that was a good, quick run through. Like I said, I would focus more on what it is and like those key manifestations than like the things like treatment and diagnosis and things like that. And I definitely know, like I said, she did focus on what is it? Like the actual definitions of the types of diseases. And I know she did ask about the Ascasian tube when I had my final, so I would definitely know what that is. So like I said, I would read over what the eyes, like the different parts of the eye do for yourself, but I don't really think she's going to test you on the specific A and P of like the eye and the ears and the other senses. But yeah, I think that's pretty much it. Is there anything else?
I think that's pretty good for patho.
Okay. I don't know if you all want to go over like key concept for farm, or if you want to go back to the med-surg portion of it. It's whatever you all want. I want to do whatever works for everyone, because I do, like I said, I have a lot of stuff for that. Oh, just I do see increased intracranial pressure for neuro. I would know that means that there's like so usually that means that cerebral spinal fluid is accumulated in the brain, and it could be from trauma or something like that. And an early sign of increased intracranial pressure would be like confusion or level of consciousness changes. And a late sign would be like Cushing's triad, which is where you have a widened pulse pressure. That means like the top and bottom number are extremely different. So maybe it's like 220/60. Bradycardia, and they have Chine-Stokes respirations, which is a type of abnormal breathing pattern. That's a late sign of increased intracranial pressure, as well as projectile vomiting. And early signs of increase intracranial pressure, like I said, is loss of consciousness or LOC changes and a headache. Yeah. And I would know those receptors, like the skin receptors for sure. Okay. Is there anything else that everyone wants to do? We could go over
I had a
farm.
question for farm.
Mm-hmm.
Did Dr. Balkin ever tell you exactly what topics are going to be on the final? Because I know it's antimicrobes, neuro, and then did she tell you there's cardiovascular meds?
Yes, from my understanding, I was texted some things from people, and I was told that on your she said in an email that there's going to be 20 questions on cardiovascular, and that includes antihypertensives, cholesterol medications, antiarrhythmias, and anticoagulants.
Okay, I'm gonna look at that email right now.
I don't know when this was sent, but I think it's in announcements. But it says 40 questions from neuro and 20 questions on cardiovascular. And yeah.
So there's no questions on antimicrobes?
Today she said,
Uh,
wow.
I saw antimicrobials too on as a part of with the neuro. Somebody told me it was antimicrobials, neuro, and cardiovascular. That's what I heard.
Oh yeah, she said so it's 60 multiple choice questions. We have 40 questions on neuro and antimicrobials and 20 questions for CV and review topics. I don't know what review topics it is. But for the neuro, she said 19, 20, 21, 22, 23, 24, and 26. And then the antimicrobial is 8, 9, 10, 11, and 12.
Is this an announcement, Lily?
Yes, she sent this November 29th.
Okay. Okay, yeah, I see.
Yeah. That's what I have too, and that there's 20 questions on antihypertensives, cholesterol medications, antiarrhythmias, and anticoagulants.
Is there any way we can go over those four?
I do have a video on antiarrhythmias
Okay.
and cardiac drugs, so I do recommend watching that. I definitely
I'll
don't
just watch
mind
the
going, yeah, I don't mind going over like key points, but I do have 2 videos for that because it is very content heavy. Because antihypertensive alone, there's like 9 or 10 classes of those. For anticoagulants, there's a couple different classes. Like there's like warfarin and heparin.
Mhm.
There's cholesterol medications like statins and bile acid sequestrants. There's an antiarrhythmias, there's like 8 or 9 classes within those on themselves. So it's very hard to like
No, don't worry
I
about it because I
think
know you have a video and your videos are super helpful. So it's fine. I'll watch the video.
okay, yeah, I was just because I'm like, it's definitely a lot, but I would say just know, right? All the antihypertensives, right? It doesn't matter the class. You're talking about like watches, it might drop the blood pressure too much. So we always have to tell our patient to change position slowly, right? And for like antihypertensives, each class has like certain things that it's known for. So like ACE inhibitors that end in like pril, like enalapril, lisinopril. You could have a dry cough or angioedema. That would be an adverse sign where we stop the medication. For calcium channel blockers that end in like pene, like nifedipine, amlodipine, you watch out for like lower peripheral edema. Diuretics, right? Like furosemide, all of those, they cause electrolyte imbalances. So you have to watch out for hypotension, right? Because it could drop the blood pressure too low, electrolyte imbalances, as well as weight, because we know that the medication's working if, they're not retaining any fluids, because a part of the diuretic's role is to remove fluids. and things like that. Like beta blockers, right? They end in LOL, so that's how you know it's a beta blocker. And it can help with hypotension. So things like that. I definitely try to emphasize that a lot in my videos. Like the key points for everything. And for like cholesterol medications, like statins, you have to give, even if they're not statins, any cholesterol lowering medication. Most common though are the ones that end in statin, like a torvastatin, things like that. Um, you have to give them at night because cholesterol is what is produced at nighttime. So if you give it during the day, it's not going to do as much for them as it would if they're taking their cholesterol medications at night. So it can prevent cholesterol from being produced if you give it to them at night or when they're about to go to sleep. And you don't give like birth control pills to someone who's on cholesterol medications like statins because they interact like, estrogen or like hormone pills. And for antiarrhythmias, you're gonna see there's 4 different classes of antiarrhythmias. I did try to emphasize in my video, like which ones are for what, but some of the most important ones are like adenosine, which is for supraventricular tachycardia, and there's very important teaching points for that. Amiodarone. You also have like quinidine, lidocaine, and some other antiarrhythmias. But just know that for all antiarrhythmias, any drug that can treat an arrhythmia can cause an arrhythmia. So even though they all help to treat an arrhythmia, which just means an abnormal heart rate, they can also cause an abnormal heart rate as a result of treating it. So that's always the problem with those antiarrhythmias. I'm trying to
Alethea,
think.
I have a question for pathophysiology. So she had said that there's 60 questions, and then she said that 60% of the questions are going to be based off of neural functions, like the chapter 11, 12, 13, and 14. And she said the other 40% is going to be comprehensive. Is that comprehensive, meaning like everything that we've covered in terms of like the musculoskeletal disorders, intergumentary, and the eye and ear disorders? Is that what the 40% is on? Or is it just on like overall what we've kind of covered throughout this semester?
Usually comprehensive means everything from the beginning. Um, so I know that's definitely scary, but like I said, I would focus on like the main key points, like what it is and the manifestations, because this is what I did. I'll be honest with you, it was very hard to study for patho, pharm, and med surg, but Balkan likes to see what you're doing in med surg. She will see what diseases you're doing there and test you on them, but for in terms of patho. So what I did is I sort of like reviewed med-surg and then included the patho a little bit more in detail as I was going over them. And last, what I remembered is Balkan did like to include concepts or things that she's tested you about in the past. So anything you've been tested on in previously can come back up again. So if I were you, if you remembered like, she gave a question on GERD, on GI or whatever, I would go back and look at that. Like whatever she tested you on previously, if you remember a topic, study that because she will definitely bring it up again.
Okay, thank you.
But is there any questions about like any of the classes? Like I said, some of the med-surg questions that I do have in the final review thing that I made could help with some of the patho because all of it overlaps. Like there's no such thing as like on the NCLEX med-surg patho and pharm. It's like some of the questions when we were going over that had to do with like medications or nutrition. She could definitely ask you like a nutrition question for let's just say like GERD or whatever. So that's why it's like I studied like med-surg primarily, but included the patho in it. Because that's how it was last year. Like whatever I was doing in med-surg were the same sorts of disorders that she was testing me on in patho. But Yeah, I'm like I said, I have until 8, so I'm willing to do whatever you all want to continue doing. If you have questions about something specific, I could go over it. Because that's pretty much the whole point of this is to help you with anything you may need help with. Yeah.
I have something specific, but also I don't know if anybody else needs help with it. I'm still struggling with figuring out the ABGs, and I know that's probably going to be a little bit on our med surge because we have ATI med surge tomorrow at 4, and a lot of the ATI questions, like a few of them were that.
Oh, I love AVGs. I could definitely do that. Is there anything else anybody wants to review? Because I'll review that now.
Yeah, I think I want to know that too.
Okay. Don't mind me. I'm a little sick. But I'm still here. So, yes, we could 1010% go over ABGs. I could definitely see that being on your thing. That's why I included in some of my questions like ABG interpretation in a way, like it was there.
And when you took your ATI med surge exam, like how is that? Because we have that tomorrow, and like I'm kind of freaked out about that because the ATIs are hard. The questions are really hard.
I'll be honest, the only way to do really good, no, I'm not saying the only way. It's not that you're not knowledgeable. It's just that ATI will test you on whatever it wants to.
Yeah.
It's not related to your class, so it is very hard to study for ATI, but there's like the dynamic quizzes section, and usually it's the same exact concepts from it. But MedSurge has 900 practice questions. So
Yeah.
there's no humanly way possible to study 900 questions. But
Yeah.
the more you do, if you could do maybe at least 100 of them on a random mode or 200 of them before, just to get used to some concepts.
So it's the dynamic quizzes on just all the chapters?
Yeah, so when you go to dynamic quizzing, they have it like separated by category. So you'll see like it'll say med surg cardiac, med surg respiratory, psych, community. Shut off like it's kind of like a select all, like you shut off a thing where it says all subjects, so then you can click which subject you want. And I would click all of the med surg ones. And I would say, because it's going to be a 90 question exam. It's going to be 90 questions. So I would say if you, yes.
How did your class do when you took?
Huh?
Do all you guys have it tomorrow too?
No.
Yeah,
I
I
already
have it
took
tomorrow.
mine for community.
Wait, was yours NGN or it was the regular one? Because we asked Professor Remy and she said it's gonna be the NGN, but I'm like, NGN?
Wait, it's gonna be NG.
Yes, we asked that today because on the ATI it have the ATI message protect exam, and then it have another one that says ATI message protect exam with NGN. So I'm trying to ask her which one are we really taking to, but she said it's going to be the NGN one.
How did your class
Probably will
when
be.
your class took it, Alicia? That was last year, right? Are you a senior now?
Yeah.
Yeah.
I didn't do good.
I have a feeling I'm gonna do good.
But like I said, it's very hard. It like okay, I think what I got right was the stuff that I knew.
Yeah.
And I would say like 50, 60 of the questions were stuff that I knew maybe or like should have known. And then there was like a lot on cancer. And I was like, I don't know anything about cancer, so I was just making
I am so scared for
educated
tomorrow
guesses.
because I think it's like 10% of our grade or 5%.
For me, it was 5%, but honestly, it really won't hurt that much.
Okay.
Like whatever you get, you can't fail it. Like the lowest you can get is a 6 out of 10.
Oh, I didn't know
Which is
that.
a 60. Yeah, so you can't fail it. Like you can't get a 0. You're not going to get the score that you get. So if you there's like the level, it's really confusing, but if you search it up, you could search up med-surg levels.
Yeah.
And like it'll tell you like the ATI proctored exam level. So if you get a level 3, that's considered 100 or a 5 out of 5. If you
thank you
get
for clearing that up. Like I'm horrified for tomorrow because I feel like I'm gonna do bad.
No. Every teacher will say just get what you get. It's okay. I think I got a 61, on it, so
That
I
makes me
got a
feel better.
level
All the-
1, which
all
yeah,
the
I
times
didn't do
I get like 70s and 60s.
yeah, it's okay. Whatever you get, the lowest you can get is a 6 out of 10. So it'll probably be like so that's out of 5 points. The lowest you can get is like a 3 out of 5. So you could, that's the lowest, or like a 2.5 out of 5, whatever that is. Yeah, I think it's a 3 out of 5. So
Okay,
you
thank
still
you.
get 3 out of 5 points. So definitely it's not gonna impact your grade that much. So just do the best that you can and don't let it stress you out.
Wait,
Thank you.
Alessia. So
Mm.
you had said that like we should use the 900 question thing that's on ATI, but can we
Yeah, let me
review by just using like the exact, like I think there's a med surge, like an adult med surge for NGN like practice. Like if we do that, it's 90 questions. Like if we keep doing that, and like I think there's a second one, do you think that's gonna help us? Or because you were
Oh
saying
yeah, I
a
mean,
lot of cancer questions too, and I don't think we really reviewed cancer at all.
no, let me show you my ATI just so I can show you how we're. I mean, personally, the A and Bs will be. I'm okay. I don't want to say will. It sometimes they're similar, and sometimes they're not. Sometimes the exams are like the A and B, and sometimes they're not. So usually, what do I don't even know where I'm going right now. So I would go to dynamic quizzes. You could see my screen, right?
Yeah, we can.
Huh?
Oh, okay. So you would go to, this is for all ATIs, which has helped me. So you would hit like new custom, and you see how it says all. I would hit clear, and then you hit adult medical surgical. You would click
I didn't even
everything,
know this was an
endocrine.
option. So thank you for showing.
Yeah, so you click everything, but all the other ones, because those would be for different classes. But you see, if you add them all up, you're looking at 900 questions. Yeah, mine had a lot of oncology, so I would say definitely maybe look at oncology a little bit, see what they have to say, but the concepts won't change. Like it will be copy paste. Also, which I didn't know about, which someone told me it was very similar to, is if you actually, yeah, I don't know what I'm doing. Let's just do this. So you go out of it, and when you go to quizzes, there's 2 types. There's dynamic and there's standard. I think there's a med surge final and a med surge one. Oh, there's one for everything. You could do these 2, or just do the med surge final. And somebody told me it was very similar to the quiz. Now I'm talking about when, not for med surge, but when we had our community ATI proctored, she said it was very similar to the ones that they had in these. So I would say like you could do these or the dynamic quizzings. I've always done dynamic quizzing, but if I were you, I would try to do like, I don't know, maybe set it for 200 questions, which I know is a lot, but and just put it on everything so that you get exposure to a little bit of everything and see what comes up. Because at the end of the day, you can only do the best that you can. But moving forward, you'll see that most of the other ATIs have a reasonable amount of questions compared to MedSurg, which has, like I said, like 1,000 questions. So besides that one, like psych or pharmacology, probably pharmacology would also be on your MedSurg, to be honest with you. But yeah.
Okay, thank you so much.
Yeah. So that's good for practicing for ATI, but honestly, I would not stress how much like what you get on it, because it's not like it's gonna do anything if you don't get like the certain score that, you know, like I said, the lowest you can get is a 60. So the lowest you're getting is 3 out of 5, which means out of your 100 points, if you get a 3, now you have 97 points left. So the highest grade you could still technically get in your class if you had 100 and everything was a 97.
Okay, thank you.
But you said you wanted to go over
Yes, the ABGs.
okay. I think this is very easy, but I think it looks harder than it is.
Yeah, I think
like
like our teachers didn't teach us. I don't, but personally for me, I did not get taught as well as I think I could have. So this is perfect. Thank you.
okay. So, I love this because I have like little tricks that I use which make it easy for me to know what's going on. So, basically there's 2 different types of like complications for respiratory. we can go into these metabolic problems. And acidosis or alkalosis, or we can go into respiratory alkalosis and respiratory acidosis. And when I say respiratory, it's because when you have one of these, you could also have the other. And what I mean by that is, let's just say you have metabolic acidosis, it's going to compensate by having respiratory alkalosis. If you have metabolic alkalosis, it's going to compensate with respiratory acidosis. So you kind of have one and you get the other. That's why I say it could be a respiratory complication, which it normally is, because if you have one of these, you have the other. So, what happens, or how can I interpret them? So, respiratory complications, either acidosis or alkalosis, the same thing. There's a same pattern. So, for the normal pH for blood is 7.35 to 7.45. But acidotic, right, would mean below 7.35. And alkaline or alkalosis would be above 7.45 because it's getting more close to a base, right? That chemistry term, right? Like 8, 10, 11, 12, 14, those were all bases. But acids were 1, 2, 3, 4. So anything below 7.35 is more acidic, and anything greater than 7.45 is alkaline. So that already tells me what my pH will be, or what my pH could be if I have either an acidotic or an alkalotic condition. For respiratory alkalosis, right, we know that that pH is going to be above 7.45. But in respiratory conditions, the opposite happens for the CO2. The CO2 goes down. So normal CO2 is 35 to 45. It could also be referred to as PaCO2, which means peripheral carbon dioxide, but there's no difference. It's the same thing. But normal CO2 is 35 to 45. So in respiratory alkalosis or in respiratory conditions, we have the opposite. So when the pH is high, the CO2 is low. For example, respiratory acidosis, the pH is going to be less than 7.35, but the CO2 is going to be greater than 45. And respiratory alkalosis, we have hyperventilation. Why? The CO2 is low because we're breathing so heavily. That's why we're going into respiratory alkalosis, which is causing the pH in the blood to increase. And respiratory acidosis, we're not breathing enough. We're breathing very slow. So the blood pH is becoming more acidic, and the CO2 is increasing because we're not breathing it off. Whereas in metabolic, it has not an inverse, but it has the same relationship. Meaning, in acidosis, we know anything acidotic means the pH is going to be lower than 7.35, and alkalosis means anything greater than 7.45. So if they're in metabolic acidosis or metabolic alkalosis, the same thing's going to happen. Meaning, if the pH is low, the bicarbonate or the HCO3 is going to be low. Or the opposite, in metabolic alkalosis, the pH is going to be high, the bicarbonate is going to be high, and normal bicarbonate is 22 to 26. So in metabolic acidosis, we have low bicarbonate and low pH. That is usually caused by things like renal failure, okay? So in renal failure, we see things like, hypernatremia, hyperkalemia, right? Because the kidneys can't function or control those electrolytes. And we will typically see someone in renal failure be in metabolic acidosis or a low pH and a low bicarbonate. Metabolic alkalosis means high pH, high bicarbonate. So greater than 26 for bicarbonate and greater than 7.45 for this. Usually metabolic alkalosis we see in someone who has an NG tube and we suction them a lot because we're removing a lot of those electrolytes. And vomiting. So when you're sick and you're throwing up a lot, you're at risk for getting metabolic alkalosis. And remember, compensatory metabolic alkalosis, you'll have respiratory acidosis. For metabolic acidosis, compensatory is respiratory alkalosis, and vice versa. So if you have respiratory acidosis, compensatory is metabolic alkalosis. If you have respiratory alkalosis, compensatory is metabolic acidosis. But How do I determine the numbers, right? Because that can be confusing. Well, the first thing I look at is the pH, right? Is it high or is it low? If I know it's low, then I know I'm dealing with something that has to do with acidosis. If it's higher than 7.45, I know it's alkalosis. So I could cross out already if it's acid or alkaline based on the pH. So I look at the pH first. Then I look at the next levels. They might give you O2. Nobody cares about the O2 level. We're going to look at CO2 and bicarbonate. One of them is going to be abnormal. So, for example, right? In respiratory alkalosis, we will see, let's just say, a pH of 7.50, a CO2 of 32, and a bicarbonate somewhere between 22 and 26. So only the carbon dioxide or the bicarbonate is going to change. It's not going to be both of them changing. So that's how you can figure out what it is. So if the CO2 changes, I'm dealing with a respiratory problem. If the bicarbonate number changes and it's not in that normal range of 22 to 26, then it's a metabolic issue. So that's how you look at it, because one of the numbers is going to be different. It's not going to be both of them. So I'm going to give you guys an example in the chat. Or you know what? I'm going to change the screen. Let's do the whiteboard. Can you see the whiteboard?
Yeah, we can.
Yeah.
Okay, awesome. Okay, so I'm gonna give you all an example, and I want you to tell me what this person is and what are they having.
Would that be respiratory acidosis?
Not respiratory. It's acidotic, but it's not respiratory.
Oh, it's metabolic acidosis because the metabolic, the peak is down and then the metabolic is down. That's the room. So metabolic is equal. But then the
Yes.
CO2 is normal.
Yes, you explained that very perfectly.
Yeah, okay, yeah, I got it. Sorry.
No, it's okay. It can be confusing, but that's why I want you to see, like, you're going to see something like this. They might even say, just to confuse you, they might add an O2 number. Don't look at that. You only look at the pH, CO2, and bicarbonate. Which one's changed? So I'm going to give you guys another one, and you tell me what you think it is, okay?
Respiratory alkalosis.
That's because that pH, right, is above 7.45. And now looking at CO2 and bicarbonate, we know bicarbonate is 22 to 26, so it's not a metabolic. So it has to be respiratory, and we said alkalosis, right? So we know if it's not metabolic, it's alkalosis, and the CO2 is going to decrease, and the pH is going to increase because there's an inverse relationship. Okay, so I'm going to give you one more.
This is metabolic acidosis.
What is it?
Metabolic acidosis. Because the pH is down. That's acid. And then
Yes, metabolic acidosis. Did everybody get that?
Yeah.
Yeah. So this is how you would do it. So like I said, you look at the pH and then you look like to see if it's acidotic or alkalotic. Okay, well, I know 7.35 to 7.45 is normal. So anything below 7.35 is acid, or above 7.45 is alkaline. Then I look to see which one's abnormal. Well, in this scenario, right, the CO2 is normal because it's between 35 and 45, but the bicarbonate is the abnormal one. It should be between 22 and 26. But remember, metabolic, they have the same relationship. So if pH decreases, bicarbonate decreases. So we know it's a metabolic condition. And since the pH is low, they're in metabolic acidosis. Did that make sense? Did that help?
You know, you doing it like this is so easy to capture. But when I see all that question and I see the O2, the PaO2, and I'm like, oh my God, what the hell is this?
Yeah,
But
no, you
like you say,
ignore PaO2. You don't care about that one.
Yeah,
oh,
this is really helpful. I think you should tell the teachers to teach it like that. Because every time I'm looking at every single thing and I get it wrong, because I know how to do, like, I know if it's alkalosis or acidosis, but then it confuses me. Well, and then can you explain how it's partially compensated and all that stuff? I don't know if they'll ask that.
I have no idea.
Okay. All right.
Um,
This was fine. Thank you.
yeah. Just know that PaCO2 is the same as like saying CO2, like I'm doing now.
Okay, perfect. Thank you.
So like if they say PaCO2 of like 38, that's the same thing. But like they might, like I said, put PaO2 to confuse you. Like I don't look at that. You're looking at it just like this. This is how I would study it, and that would help me on how to figure out what is what. And like I said, the reason I explained if you have compensant, remember, they might say the patient's in metabolic acidosis, but none of the values show metabolic acidosis because they could have compensatory respiratory alkalosis or vice versa. They could have respiratory acidosis, but the answer is going to be something with metabolic alkalosis because that's the compensatory mechanism. So just think about that, right? Like if it doesn't have like, it might say which of the following is an example of like one of those, right? You know what you expect to see, but think if you don't see it there, they might be asking you to know, well, I know the compensatory mechanism will be the opposite. That's why I explained it to you like that, because I've had a question like that where I'm looking for metabolic acidosis or something, like I'm like, I don't see this. And I'm like, oh, wait a second, they have compensatory respiratory alkalosis. So this would be the answer. I hope that made sense.
Yeah, it made sense. Thank you.
Okay. Is there anything else that you all want to review? Because like I said, I'm here till 8, and then after that,
Could you go over the anticholinergics? I think that's what they're called.
is that going to be on your final?
That's what she was saying. We just had a review earlier, and she was saying like that's gonna be like about 20 questions. Like last 20 questions.
well, is that CNS the neuro?
Yeah, for neuro.
Okay. If anticholinergics are on there, we could definitely talk about that. But yeah, let me see. I have to send myself my notes because I have notes all over the place. Which I don't like, but you know, I gotta do what I have to do. So anticholinergic, right?
Yeah.
That's what you're saying is on your final. I think I know why. I think because some of these drugs can be used for like overactive bladder, like things like that, like drugs for those. Okay. Because cholinergic drugs are used for things like myasthenia gravis and what else? Like Parkinson's. Is that what you mean, cholinergic or anticholinergic?
I think that might be what I mean.
Okay, I'm just making sure because
Yeah.
I know you're going over neuro, but the cholinergic drugs are the ones that we use for like those disorders, and I think that's what she's referring to, or
Okay.
what you mean. Because I was getting a little confused. I'm like, those ones? I was like, okay. Now I gotta send a different one. All right, where is this? Okay, so I'll share my screen quickly. Like I said, I know I didn't get to go over all the med-surg questions. Oh God, where did it go? Oh, it's right there. But if you want them, please, I think they'll be great review for your med-surg final. I definitely tried to put together like a lot of good questions, and I hope they were good questions when whoever was here to see them. I just wanted to like help with getting your brain thinking because the questions can be confusing.
Yeah, they were helpful. Are you gonna post those questions somewhere?
Just text me and ask me.
Okay,
I'm
I
not gonna
will.
know who was here, but yeah, I have it for everything, so it should be like a good review for everything that you learned, especially on neuro. I have a couple of good neuro questions on there.
Perfect. I'll text you.
Okay, so the thing with cholinergic, remember how I was talking about in one of the questions, we were talking about someone who had bradycardia, we were talking about atropine, right? Atropine is an anticholinergic drug, which is actually the antidote for a cholinergic crisis. So if we give these drugs that we're going to be talking about and they overdose in them, we can give atropine, besides it being a drug that we could use for bradycardia. Now, I tell everybody, because I emphasize in my videos over and over again, because I had Dr. Badowski, so I emphasize the same thing over and over. He said SLUD. Now, remember, parasympathetic is the opposite of sympathetic, right? So those anticholinergics mimic.
Sorry, could we review both cholinergic and anticholinergic? Because I'm like reading my notes and I think she definitely said anticholinergic because she kept stating how like, because I know it's used to block and inhibit like ACH and so it could be used to treat Parkinson's, and she's gonna ask us questions on Parkinson's. And she was also talking about how like because she kept saying like you shouldn't give anticholinergics to patients with enlarged prostates or with people who have closed angle glaucoma. So I think she was definitely mentioning or referring to anticholinergics. But maybe we could go over both of them since they kind of have to do with neuro anyways.
Okay, but I think I'll be able to explain them in a way that you won't necessarily need to go like into both of them, because if you know one, you know the other, and I'll explain why.
Okay, that's
So,
perfect.
yeah, definitely I know exactly what you mean. So, I'll explain with the anticholinergics. I'll bring that up in a second. I don't have actually much notes on that, so I think I'll be able to go over everything. I'm very good with. I love pharm. I absolutely love it. So I this is like my favorite thing. So I definitely think out of all categories, this is my area of expertise. But so the only way you can understand cholinergic and anticholinergic is SLUD, or SLUDD. It stands for, the S stands for secretions or salvation. The L stands for lacrimation. The U stands for urination. The first D stands for defecation or going poo-poo. And the last D, or the second D, is for digestion. Now, why do I mention that? Is because parasympathetic, there's two different types of receptors. There's muscarinic and nicotinic. We're going to specifically be talking about how acetylcholine, that one, binds to the muscarinic receptors. This is the ones that we're talking about. Nicotinic are more for those neuromuscular junction blockers. But for these, we're talking about muscarinic because they're everywhere. They're like those sympathetic receptors. But for SLUD, right, parasympathetic promotes SLUDD. It promotes secretions and salvation. It promotes lacrimation. It helps you pee. It helps you go to the bathroom, and it helps you digest food because it's parasympathetic, or cholinergic drugs work on the parasympathetic system, which is our rest and digest. Sympathetic, right, is the opposite of parasympathetic, or what I call anti-SLUD. So it prevents salvation, lacrimation, urination, defecation, digestion. That is why we give anticholinergic drugs like oxybutynin for an overactive bladder to reduce urination. And we wouldn't give a cholinergic drug because they would promote urination when this patient's already going to the bathroom too much. Do you see what I mean by if you understand one, you understand the other in a way? I think you guys are getting it. I'm going to take silent as yes. So,
Could you repeat that again? So you said that cholinergics promote like urination, and so that means like anticholinergics would do the opposite, correct?
yes. Exactly, right? So if you have an overactive bladder, meaning you're peeing so much, anticholinergic drugs treat an overactive bladder. And the most commonly given anticholinergic for an overactive bladder is oxybutynin, which is an anticholinergic drug, so it causes anti-slud, anti-salivation, lacrimation, urination, defecation, digestion, which prevents you from going to the bathroom as much. So this helps our patients who have an overactive bladder, right? I wouldn't want to give them a cholinergic drug who promotes slud because then they're going to be peeing even more, and that's not going to help their overactive bladder. We want to prevent them from going to the bathroom. So cholinergic promotes slud or promotes that acronym, whereas anticholinergic prevents the acronym or prevents slud from happening. So, like I said, cholinergic, we're talking about prolonging acetylcholine, which increases parasympathetic effects. So we're increasing that motility or GI secretions, our ability to digest and defecate, okay? We're talking about decreasing the heart rate, slowing things down. It could also even cause bronchoconstriction because parasympathetic is our rest and digest. So we slow down respirations, right? We don't really need as many respirations if we're eating or going to the bathroom. But in sympathetic, it's more of our fight or flight response. So we need to be able to have bronchodilation. And sympathetics promote bronchodilation. So, but like I said, the main thing is slud, and you'll see why, right? So, we talked about, right, atropine would be the antidote if they were to have a cholinergic crisis or if they were to have an overdose and let's say these cholinergic drugs. And we have a few different type of cholinergic. We have direct acting or indirect acting. The indirect acting is actually going to work on some of those disorders in neuro by we're inhibiting an enzyme that breaks down acetylcholine, which prolongs the action of the parasympathetic system. Whereas direct acting binds to those cholinergic muscarinic receptors and produces slud right away. So we also call cholinergic drugs parasympathomimetics, meaning they mimic the parasympathetic system. Muscarinics are everywhere. All of your organs, so your sweat glands, your heart glands, that's why your eyes, everywhere. It's all smooth muscles, a lot of them, okay? So that's why we see them in your eyes, right? They can cause miosis or eye constriction. That's because you're looking at things in a closer way. So if you're looking at things in a more close appearance, your eyes constrict, right? It increases GI mobility or pooping and digestion. It helps with salivation. It helps you go to the bathroom, but it also can cause a decreased heart rate and bronchoconstriction. But those 2 to 5 that you see here are slud, right? It helps you go to the bathroom. It helps you salivate. It helps you lacrimate. It helps you poop. It helps you digest your food. So
you mentioned that the cholinergics is kind of like a parasympathetic, it's parasympathetically related. Does that mean it's kind of also similar to GABA? Since GABA calms, and then like parasympathetic is like the rest and digest of the body, so it's a more calm.
I see what you mean. GABA is not like parasympathetic. It does slow, but GABA is a central nervous system depressant. So if we mimic or work on those GABA receptors like those benzos or those antidepressants do, we're shutting down almost everything because it's in that central nervous system. These are in that autonomic nervous system, so they're more peripheral. So they're not located directly in the brain. So, right, if we have those GABA receptors activated, we can have depression of all systems. Whereas with parasympathetic, it could like slow down most systems, but not as severe as the CNS depressants like those GABA receptors are. Does that make sense?
Yes, it does. Thank you.
But yeah, there is definitely a similarity, right? It's that those GABA receptors slow everything down, but they also slow down your ability to go to the bathroom and things like that. These don't. Parasympathetic stimulates your ability to go to the bathroom.
Oh, so the parasympathetic is like the opposite of the sympathetic. So if you have the SLAD, you have the anti-SLAD. So they are like, apart from the medications, their benefits is like opposite of each other.
Exactly. So if you have SLUD for parasympathetic, you have anti-SLUD for cholinergic or sympathomimetics. They mimic the sympathetic system, right? For example, if you're running from someone, you don't need to poop or go to the bathroom, but you need bronchodilation in order to run. That's your sympathetic system. And parasympathetic, it's kind of like what we're doing right now. Sitting, talking, right? This might make you feel if you're drinking some water, you want to go to the bathroom and things like that. So that's what this is. And that's why I said if you know one, you know SLUD or SLUDD, you know that anticholinergic is anti-SLUD. So all the side effects are going to be no lacrimation, no defecation, no urination, things like that. But, okay. So like I said, these are cholinergic drugs. So we have like neostigmine, pyridostigmine ending drugs. And they can even be used for eye exams, okay, because of the way that these drugs work. But one of the most prototypical drugs that we see is bethanchol. I don't know how to say that. Atropine is an anticholinergic. See, muscarinic agonist versus a muscarinic antagonist or anti-SLUD. So Bethanchol is a cholinergic drug, and atropine is an anticholinergic drug. And atropine is good for an antidote if they were to go in a cholinergic crisis. So we said, once again, acetylcholine receptors are the ones that are going to promote parasympathetic. Okay? So right?
What would be an example of a cholinergic reaction that we would give atropine to?
Oh, I will show you. It's at the end of my notes because it's called dumbbells. So if they're gonna have overstimulation of parasympathetic, think about it that way. It's gonna be like parasympathetic stimulation times 2. So much diarrhea, so much urination. They're having pinpoint pupils. They're having a really, really, really low heart rate, like maybe 30s. They're vomiting. They're lacrimating, but too much. Now they're becoming lethargic and confused, and they're overly salivating. Okay, if we're giving them a cholinergic drug, they're becoming confused and they're having these pinpoint pupils and their heart rates at the 30s, we're going to give them atropine. So that's how we know they're in a cholinergic crisis. But, okay. So where is my drugs that I was talking about? So, Bethanchol is one of those drugs that we can give for urinary retention and neurogenic atony. So what that means is urinary retention, they're holding on to urine, and neurogenic atony is when they have a surgery and for some reason their bladder just can't go. So we can give them this. Why? Because it's cholinergic. Why? Because it promotes SLUD, and SLUD promotes urination. So this is amazing, amazing for someone who has urinary retention. It's going to help with that. We can also use it for myasthenia gravis. Why? Because myasthenia gravis causes muscular stiffness, right? And parasympathetic relaxes. So it could help with that that over sort of stimulation that they're getting.
So like the myasthenia gravis, where there's dryness, like there's less secretion, this medication which increases secretion helps that disorder.
Exactly, because it's going to increase that. Yeah, the things that they're not able to get. So once again, if we see them having a cholinergic crisis, we give them atropine. Now, like I said, the drug of choice for an overactive bladder is the anticholinergic drug called oxybutynin. And that is because it's anticholinergic, so it's anti-SLUD, so it prevents you from peeing. Isn't that great? Anti-SLUD. And the adverse effects are SLUD, because anytime a drug acts on a certain receptor, the adverse effects are basically what it does, right? Because a cholinergic crisis is too much SLUD. Salivation, lacrimation, urination, defecation, digestion. And see, with things like that, right, we also, right, couldn't give a cholinergic drug to someone who has asthma. Why? Because it's a parasympathetic stimulant and it causes bronchoconstriction. And if somebody has asthma, they already have the risk of bronchoconstriction, and parasympathetic closes the airways a little bit. So, not good for asthmatics. The same way, those beta blockers, right, that worked on those beta 2 receptors, we can't give them to asthmatics because they cause bronchoconstriction. Same concept. Another one that is a cholinergic drug, we call this pilocarpine. We use this to treat xerostomia, which means dry mouth. Why? Because it causes SLUD, it causes salivation. Doesn't that make sense? And it could also treat glaucoma because it could help decrease some of that intraocular pressure. But it can't help with closed angle glaucoma. It could help with like open angle glaucoma. So you're seeing how some of these drugs work. Like I said, I don't understand the specific mechanisms of how it decreases like the pressure in one type of glaucoma versus the other. But remember, closed angle glaucoma, please correct me if I'm wrong, but when we were talking about it, we were talking about how with that one, I think it's a little bit more of it could be, wasn't it acute, subacute, and chronic? So it could have different types. I believe that's what we said for that one, that it had different types of glaucoma. So I don't think this medication would be able to treat the different types, but it can decrease intraocular pressure, but it also helps remove any sort of tension. So for this medication, we're going to tell them, hey, you know, you need to have frequent eye exams because this drug can help treat your eyes. And we want to make sure that, you know, it's not causing any problems. You know what I mean? So, like I said, an overactive bladder, we can't give a cholinergic drug. So we have to give an anticholinergic because they have urgency and incontinence. So we give oxybutynin because it is a cholinergic antagonist. Then we have indirect acting cholinergic agonists. So like I said, they block those enzymes from breaking down acetylcholine, and that promotes the duration of acetylcholine, therefore causing parasympathetic effects. So how does it work with myasthenia gravis? Well, it targets those acetylcholine receptors and destroys them, which prevents muscle contraction. Because remember, this myasthenia gravis, they have a lot of muscle weakness and they lack muscle control, and parasympathetic helps relax some of those actions. So we're preventing those muscle contractions that they can get from that lack of muscle control with myasthenia gravis.
So
Does that make sense?
for myasthenia gravis, we're giving the cholinergic compound because it targets and destroys the ACH. But isn't the patho for myasthenia gravis like it's an antibody destruction of the ACH receptors? So how is why is giving the cholinergic compound also and destroying that acetylcholine, like the ACH inhibitor is like helping that?
That's a good
If that
question
makes
because these do, yeah, I know what you mean. It doesn't destroy the like the receptor itself. It destroys the enzyme that destroys acetylcholine. So myasthenia gravis targets acetylcholine receptors and wants to destroy them. Cholinergic drugs bind to the acetylcholine receptors so they can't be destroyed.
Oh, got it. Thank you.
Yeah, so myasthenia gravis wants to destroy acetylcholine receptors, which basically prevents muscle contraction and causes muscle weakness. So we give them the cholinergic drugs to bind to those acetylcholine receptors to reduce the muscle weakness and lack of muscle control, which is going to help them to be able to move their muscles because it binds to that receptor. It takes the place of the myasthenia gravis. Says, nope, you're not going to bind here. I'm coming here so that these receptors can work. Otherwise, as you said, they're going to break them down and it's going to promote muscle weakness. Why? Because it's parasympathetic. It's going to slow things down even more. It's going to make it even weaker, right? If we're targeting those receptors. But if we're binding to it, we can prevent that breakdown and prevent the weakness that this disease is causing. I hope that makes sense.
Yes, it does. And so a manifestation for myasthenia gravis is neuropathy or no? It's just the muscle weakness, stiffness, and the dry mouth. Is neuropathy part of that?
I don't know. I'd have to check my notes on that in my med surg notes, but I don't think so. I just know it's more or less the main part is that it has the muscle weakness. That's what it causes. And we give them cholinergic drugs to reduce the muscle weakness and promote muscle contraction because it's going to bind to in those receptors and prevent them from being broken down.
I would say you said neuropathy?
Neuropathy, yeah. What about it?
I would say it will be more like the Guillain-Barré syndrome, not for myasthenia gravis, because the myasthenia gravis, they have nothing to do with the nerves. It's more like the receptors,
Oh, okay.
ACH receptors. But then the Guillain-Barré is more like the nerves, like multiple nerves of the body.
It is a nerve problem and it's an ascending disorder. So Guillain-Barré syndrome starts in the lower extremities causing weakness and numbness and it comes all the way up to the arms and the chest. That's why a priority intervention, which I know she put this on one of my quizzes with Dr. Boken, was that you have to have respiratory interventions because it ascends to the lungs and it can cause the lungs to stop. That's the thing with Guillain-Barré syndrome that's different than the rest, is that it can cause respiratory complications. I talk a little bit about the differences in my med surg neuro video if you just wanted to listen to that to hear a little bit more of the differences if you wanted to understand them better. But yeah, myasthenia gravis, the goal is to target these acetylcholine receptors and break them down. But it can't break down what it can't get to, right? So if it can't get to these receptors, they can't be broken down. And all of these drugs that end in stigmine are the drugs that we give for myasthenia gravis. That's because, they do have, this is related to neuro because remember, myasthenia gravis and these drugs work on neuroreceptors. So there is an interplay because you can't have movement or weakness without that interplay between the neuromuscular joint or the neuromuscular junction. But you see, all of these drugs that end in stigmine are actually antidotes for those neuromuscular junction blockers that I don't know if that's on your exam, but if they are the antidote for those. But anything that ends in stigmine, we can give to patients who have myasthenia gravis. Now, interesting, what I would know is this drug, especially endrophonium. It's a diagnostic agent for myasthenia gravis. So what happens is that it's a short-acting drug. So it's going to stimulate the muscle. So it's going to bind to those acetylcholine receptors, make them move, and then it's going to, it has a short-acting nature. So it's not going to last very long in the body. Its effect is going to wear off very quickly. And then the muscle's going to go back to how it was before, which is weakness. If it does that, right, when we give this drug and that patient has a stimulation in muscle contractions and then it goes away, that proves that they have myasthenia gravis. So idrophonium is the diagnostic agent for myasthenia gravis. And we give drugs like neostigmine, pyridostigmine to treat myasthenia gravis, the symptoms. So also, right, these drugs are called indirect acting cholinergic drugs. But some of these indirect cholinergic drugs can also be used for Alzheimer's. Not those, but this class of indirect acting. So this indirect acting, the ones that end in stigmine, those drugs can be used for myasthenia gravis. And the diagnostic agent is idrophonium. And remember, adverse effects are SLUD. If they have if they have a cholinergic crisis, we give an anticholinergic drug like atropine. So, right, adverse effects are SLUD. Increased lacrimation, increased salivation, increased urination, increased defecation, increased digestion, things like that, and as well as bronchoconstriction and decreased heart rate, right? Remember, we're not giving this to asthmatics because of that idea of bronchoconstriction, and we wouldn't want to give this to someone who has a history of bradycardia, right? It wouldn't make sense because this drug can cause bradycardia, things like that. So, remember, right? Like we're looking at these drugs. We talked about what they do and how they work. So always, right? You always want to get a good history. You want to have an EKG because a bradycardia is considered an arrhythmia or an abnormal heart rate. So we want to watch that, right? Watch out if they have a history of GI obstruction or urinary retention, and things like that. Why? Because this is going to be very painful if they have any sort of urinary or GI obstruction. We're trying to make them go to the bathroom, but they physically can't. That might hurt and put a lot of pressure. So we need to look at their history, okay? And we also want to know their level of consciousness, right? Because they can have a cholinergic crisis and go in and become lethargic. So once again, anything that ends in stigmine, we're talking about cholinergic drugs that treat myasthenia gravis, okay? And if it gets really, really toxic, we could have CNS depression, but that's if there's too much stimulation of it, that it gets too extreme. But usually that's not the case. Now, like I said, we have to be really careful. Adverse effects are SLUD, so we really have to watch out for that if they have a cholinergic crisis. Now, Alzheimer's disease is a progressive disorder that involves neural degeneration. So there's some sort of neurons being broken down and not really being able to work, which leads to memory loss and inability to do your day-to-day things, okay? It causes loss of those acetylcholine receptors in the central nervous system. So we have drugs that prevent, right, the breakdown or the loss of acetylcholine receptors. These drugs are going to slow or delay the process of this, but they're not going to stop Alzheimer's disease, okay? So they usually treat mild to moderate types of Alzheimer's. They slow the progression, but they do not cure it, okay? So adverse effects, SLUD, right? Gastrointestinal dizziness from that bradycardia, potentially, bronchoconstriction, gastrointestinal effects, meaning going to the bathroom a lot or peeing a lot and things like that. So here's the drugs that we can use for Alzheimer's. For Alzheimer's dementia, we could use Tutoring. To slow the progression of Alzheimer's, we could use galantamine. Rivastigmine is, I would know this as the only available solution for swallowing ease because it's liquid form. Okay, so the other ones are pills, but rivastigmine is available in a liquid solution to help for patients who have issues swallowing. And donepezil is a once-a-day dosing, okay? But these three, galantamine, rivastigmine, donepezil, they are only used for mild to moderate Alzheimer's disease. And yeah, like I said, they work on those acetylcholine receptors by slowing the progression, by inhibiting that acetylcholine enzyme from breaking down those receptors, so it prolongs parasympathetic stimulation, but the adverse effects are SLUD. And we could also have falls as another adverse effect because they can get really dizzy. And remember, they're having a progressive neurodegenerative disease, and they're getting, losing their memory. They're not being able to really do their activities of daily living, so they are at a higher risk for falls, okay? The only one that's irreversible is rivastigmine, that one that comes in that liquid form for swallowing ease. So we have to be careful. That sort of means if we were to have a problem with this drug, we couldn't fix it. Do you understand what I'm saying? Irreversible means we can't fix it. The other ones are reversible. We can make the changes if something were to happen. And yeah, so all the same thing. Adverse effects are SLUD. They all got to watch out for falls, right? That bronchoconstriction, that bradycardia. And then we also have memantine, which works differently. It works on this N-methyl D-aspartate receptor, which is really, really different. And it could be better tolerated than some of those other drugs. So this is another drug that we can use for Alzheimer's, but it doesn't work on those acetylcholine receptors. But it has a similar mechanism of action, right? The goal is to slow the progression of the disease. It works on different receptors, but it can cause dizziness, headache, confusion, and constipation. And yeah, so we have drugs for neuropsychiatric symptoms like risperidone and olanzapine. These are psychotherapeutic drugs, okay? So those are like those if you saw the video that I made on antipsychotics, that's what we're talking about here, right? So that's a whole different conversation. But yeah, and just some more about the pathophysiology of Alzheimer's is that it's degeneration of neurons. It starts in that hippocampus where we have the memory, that's where memory forms, and then it starts to affect that cerebral cortex where it affects speech and reasoning, right? It causes a loss of those acetylcholine receptors. So we bind to those acetylcholine receptors to prevent the loss, okay? And if they have a cholinergic crisis, remember, except rivastigmine, that's irreversible. Everything else, if they have that, we can give atropine. If they experience dumbbells or diarrhea, urination, meiosis, or pinpoint pupils, bradycardia, emesis, lacrimation, lethargy, and increased salivation. And yeah. And one more thing that I wanted to point out is that the one that's irreversible, right? Let's just say it takes 45 minutes to 1 hour for it to bind to it, like rivastigmine. Once it binds to that enzyme, if it does within that 45 minutes to 1 hour, you're done. It's going to be permanent. If they go into a cholinergic crisis, that's it. So if they're showing symptoms within 20 minutes, give them atropine. It's only going to work within that first 45-minute window. So you have to really watch them. If not, if they go into a cholinergic crisis, there's nothing we could do for them. That's also what I wanted to point out for you. And yeah. And like I said, anticholinergic would be used for an overactive bladder because it prevents SLUD, so it prevents urination, which helps you not pee as much. Is there any questions?
Yeah, so atropine is just given when like the other medications are like causing effects. So it's not like a medication, it's just like naloxone. It's just an antibiotic for crisis. You don't give that medication.
No. Yes, it is used as the antidote, but remember, atropine is also used for bradycardia. That is a part of the antiarrhythmia drugs. Atropine is used to treat bradycardia. Why? Because it's anti-SLUD, because it's sympathomimetic. It stimulates that sympathetic nervous system, which causes an increase in heart rate. So when someone has bradycardia, we give them atropine. So that's the other use. So there's two uses of atropine, for a cholinergic crisis or if they're bradycardic. And let me just see something. I have it over here. So I could just show you. And it's actually the anticholinergic drugs like where is it? I can't think of the name right now. Oh, ipratropium, right, is one of those short-acting bronchodilators that we can give for a patient who has an asthmatic attack, right? If they're having an asthma attack, we can give them ipratropium. We give ipratropium, an anticholinergic, in a situation where a patient has an asthma attack, right? Because it works very quickly and it promotes bronchodilation, right? Because parasympathetic normally causes bronchoconstriction, but if it's anti-parasympathetic or anti-SLUD, it's going to promote bronchodilation. So ipratropium is a second-line agent if our typical albuterol is not reacting very well in our patient. We can give them ipratropium. Now, like I said, atropine is good because it can also stop secretions, right? So you can give this prior to a surgery. It prevents bradycardia, and it's also used as an antidote for a cholinergic crisis. And scopolamine is another anticholinergic drug that prevents motion sickness in patients. And yeah. So that's the that's what we can use. This is all the things that you could use atropine for. So you could use atropine for bradycardia, for a cholinergic crisis, to relax bronchospasms, right? Because it promotes bronchodilation, restore heart rate and blood pressure, things like that.